Good morning and welcome to the 14th meeting of the Health, Social Care and Sport Committee in 2025. I've received no apologies for today's meeting. The first item on our agenda today is for the committee to agree to take item 4 in private. Are members agreed? The next item on our agenda is to continue taking evidence on the Right to Addiction Recovery Scotland Bill. The committee will hear from 2 panels of witnesses today. As our first panel, we will take evidence from representatives of a number of third sector organisations. And I welcome to committee Kirsten Horsburgh, Chief Executive Officer of the Scottish Drugs Forum, Tracy McFall, Chief Executive of Scottish Recovery Consortium, and Justina Murray, CEO of Scottish Families Affected by Alcohol and Drugs. A fourth witness, Laura Mahon from Alcohol Focus Scotland, is unfortunately no longer able to join us this morning. So welcome to you all, and we'll move straight to questions. And Elena Whittam.
Thanks, Convener, and good morning to the witnesses. Thank you so very much for coming in this morning. I want to explore the actual right to recovery as it's set out in the bill, and explore a little bit about what it means to be a rights holder and a duty bearer. So the first question I have is, to what extent will the provisions in the bill ensure that the rights of people who use substances are realised, and the way I think that we would all like to see them realised? So I don't know who wants to kick us off. I'll maybe start with you, Kirsten.
Yeah, sure. Thanks so much for the invite to come. So firstly, probably just to set out the context of where we're coming from with our response, is that we absolutely welcome that this bill has created a national conversation about what are the problems with the treatment service, and that it's really shone a light on the issues around access, choice and the quality of services. And whilst we agree with that conversation, we do not agree with this being a legislative process, because the issues that are at the core of the treatment service problems are around access to immediate treatment, the quality of that treatment and the disempowerment that's felt by people who use substances when they're accessing. So a legislative process, these are not legal issues, these are issues of culture, of capacity and of resourcing. A legislative process would not guarantee the improvement of the quality of services, and it certainly, would not help to enhance that access that people are looking for, and it wouldn't guarantee the person-centred therapeutic approach either. And the bureaucracy, the confusion, the legislating for clinical decision-making is also a concern, and we are concerned that that wouldn't provide any meaningful change. And finally, what we do need to be doing is fully invest in implementing the standards that are already there, and also the recommendations that have been made time and time again to improve all the accessibility, acceptability and equity of services across the country, and fully embed in lived and living experience perspectives in service design and delivery.
Thanks very much, Kirsten. I don't know if either Justina or Tracy would like to come in.
Yeah, just to say, from a Scottish Recovery Consortium perspective, we see your discussions and input into this bill as we want to be constructive. But what you do know, and what we do know in Scotland in relation to legislation, as Kirsten said, because it's in law and legislation does not mean people will access their rights. We know that in terms of housing legislation, we know that in a range of different bills right now. So in terms of Kirsten's point around the fundamental issues in Scotland around treatment and access and choice and quality are absolutely fundamental. In principle, we all want to see people access their rights in relation to treatment, but for SRC there would be a range of changes that would be needed in the bill in relation to if the bill was to go through, and that's about addressing the power imbalance, it's about alignment with the current standards, it's about a human rights based approach, and it's about ensuring that people with lived and living experience are included in this process. So yes, we all want people to access their rights in relation to treatment. However, just because it's in legislation does not mean that that will come to fruition in Scotland. So there's many things that we need to talk to in relation to that.
Thanks.
Yeah, I just wanted to make a point more about general human rights. Human rights are for everyone. They're universal. We all have human rights. I can't give you your rights. You can't give me my rights. We can recognise and uphold them. But I think similar to the points that have been made already, we are not supportive of this progressing through a legislative route. And there's a lot of kind of gatekeeping of rights and conditional rights built into the bill. So in our view, it's fundamentally flawed.
Thank you. I would also like to explore a little bit about how it could potentially enhance or run into conflict with the Charter of Rights that has been worked on for quite a while now. Because I think that if we look at the Charter of Rights, and that was to be underpinned by a Scottish Human Rights Bill, which has now been delayed, and I have a huge concern that we will enter a vacuum where people are unable to actually challenge effectively so that they do realise their rights. So I'm wondering whether the bill as drafted could complement that, or whether there was any space where the two could conflict with each other.
I think from an SRC perspective and the people that we've spoke to, it's not just the Charter of Rights. You have the National Care Service Charter of Rights Bill, Charter also. So there is a range of different things that potentially we'd need to be creating synergy around this bill. And what we have is, whilst there is a range of conversations about the Charter of Rights, the National Care Service Charter of Rights, this bill, what you have is individuals, families and communities in the middle of this trying to navigate a really complex system to access what they need in terms of to keep them alive. So, and I think fundamentally that's what we always need to keep bringing this back to. The more complex we make it, the more difficult we make our systems in terms of complexity, the harder it will be for families and communities to navigate. So I think you're absolutely right. Right now, there is no synergy in this bill in relation to the Charter of Rights, or actually more broader in relation to the National Care Service Charter of Rights either. Elena, that makes sense.
Yeah, just yeah.
The Charter of Rights we think is a really helpful document, and it sits as part of this suite of rights-based documents along with rights, respect and recovery, the MAT standards, but also like the Patients Charter. I'll come on to carers' rights later. So we think the Charter is very helpful. However, we also know that family members and their loved ones need a lot of support to understand their rights, to access their rights. Through our My Family, My Rights programme, we've done a lot of work around that. So none of these things, just by saying to families, you've got rights, isn't it fantastic? We know that doesn't really change the world for them, but actually providing them with the knowledge, skills, confidence, connections to access those rights, that really has been a game changer.
Thanks. And just to add on your point that we'd, as part of our response, had consulted with people with living experience of substance use across the country. And one of the key comments that they made was that they're only just getting their heads around the MAT standards and the Charter of Rights and cannot see how that legislative process would enhance those or support those, and actually is quite conflicting in terms of certainly some of the stuff in the MAT standards. So the legislative process within the bill as proposed completely misses the real-life experiences of people who are trying to access services.
I suppose the final question I would have then is to think about how does an individual or a family and an individual actually challenge decisions where they're not getting access to the support that they believe that they require, because to me that feels that is the nub of the issue. So if they don't actually have a right within a set of legislative measures, what is the remedy for them? Do we have an absence of a remedy at the moment?
I was just going to say the bill's actually silent on that. It doesn't talk about what you would do to challenge your rights beyond seeking legal redress. And families' views on that is who has got the money for that? Never mind the knowledge, headspace, time. It's not an appropriate route for redress. And through existing advocacy services, which do need to be strengthened, we can support people through existing complaints processes, stage 1, stage 2, stage 3, up to the Ombudsman. We know that does sometimes succeed in terms of families feeling heard, and that the issues that they had raised have been listened to. However, it's not a perfect system, but the bill doesn't really solve that. It just adds another layer of legislation. And as we've already reflected, that Scotland is full of legislation that's not effectively implemented just now.
Thank you.
Yeah, and just to add, I think Justina is absolutely correct. There has been investment in independent advocacy organisations, specifically with a role and remit to support those who want to challenge the system and make complaints in relation to access to alcohol and drugs, but there is not enough investment. And actually it goes back to one of the points Justina said, is to access your rights, you need to know your rights. And I think there is a massive gap in Scotland in relation to fundamentally individuals, families and communities understanding their rights in Scotland in relation to this.
Thanks all. Thanks, Convener.
Thank you. Emma Harper.
Thanks, Convener. Good morning to you all, and thank you for being here today. The bill requires a relevant healthcare professional to diagnose individuals with a drug or alcohol problem and then provide a treatment determination. So I'm interested to hear what your thoughts are regarding the requirement to receive a diagnosis before somebody can enter into treatment.
I'm going to go first. Share it around. Yeah, I mean, that is obviously, Justina mentioned gatekeeping earlier, and that's a key part of that. You know, that allows a system where there is gatekeeping based on whether or not you have a diagnosis or not to access any specific treatment. The whole process itself creates something that's adversarial rather than collaborative. We don't want this to be a battle, right? So we don't want the situation where people are having to challenge treatment decisions. We need to get to the root cause of why people aren't being offered the treatments and support that they want and they require when they present. So there's a lot of work around, you know, a whole range of things that we could be doing to improve the treatment service so that we're not even reaching that point. Independent advocacy is a great point to make because it's also not mentioned in this legislation. So, yeah, a range of workplace and workforce developments that would also be very beneficial going forward, but I'll save that for later potentially. Thanks.
And probably just to add, the people that SRC have engaged with across the country in relation to this bill, there was a really key theme, and that was around the stigma based on the diagnosis of addiction. And that being in medical records and the implications of potentially that being in your medical records and the implications around jobs, access to training and education. There is also something for me around when people are in crisis and they need to access treatment, there is an intervention point where you start to build that relationship. The difficulty for me, and I think it was said in one of your other committees, is the time it takes to make that diagnosis and whether that actually delay treatment. And I think that's a really significant issue that is not addressed in the bill and would need to be explored further in relation to that. But the big thing that's come out really strongly with the people that we spoke to is the stigma attached, and not everybody recognises the term addiction and they don't see themselves in that space. So that's really, really fundamental around the stigma attached to that.
And just to come back on that, some people might not want to seek that diagnosis then, or they might, it would prevent them from coming forward for maybe accessing to care or treatment because they might know within themselves they have a problem with alcohol or drugs, but then actually just don't want to hear that. But yeah, it's a way to get them into treatment without a diagnosis.
Yeah, I mean, we've done so much work with Scotland as a nation to understand the difference between alcohol and drug use and alcohol and drug harm. And we want people to recognise, you know, that they can get support if they are concerned about their own drinking or drug use, or if family members are concerned because there's a level of harm there. And I think this returning to the sort of clinical diagnosis is so narrow. And it's been well covered in the previous evidence sessions. You know, for example, thinking about alcohol, a tiny minority of the population would be clinically diagnosed as dependent on alcohol. But, you know, 25% of the population are drinking at levels that risk their health. And, you know, people die from alcohol all of the time and cause themselves harm who would not be diagnosed as being clinically dependent. So it just seems to be really unnecessarily narrow. And again, just strengthening that power imbalance that already exists between health professionals and people seeking support.
Okay, I think that's been good.
Jane Mackay.
Thanks, Convener, and good morning to the panel. Does the bill adequately promote collaborative working between health, addiction and broader support services to ensure the holistic approach it seeks to achieve? And could I maybe go to Justina first?
Yeah, well, no would be a quick answer to that. There really isn't any reflection in the bill about the importance of multidisciplinary teams, of collaborative working. You know, it's pretty silent on the role of the third sector, for example. And all of the things that happen around somebody where there's harmful substance use aren't really touched on at all. You know, mental health issues, relationship issues, you know, issues with housing, finance. Where's your right to support for all of those things? And it really, again, has this very overly focused and minimal focus on a clinical diagnosis of addiction without any responsibility for responding to all of those other needs that people have.
Don't know if anyone else wants to come in at all, convener.
Just to add, what we know around problematic substance use, alcohol and drug use, is it's complex. So the medical treatment element of that is one very, very small part of everything else that needs to be wrapped around individuals, communities and families. And we know that in Scotland, and the evidence base is really, really clear. But if you look at the UK guidance and drug misuse and dependence, that's really clear also that the clinician's role is to support and assist joint decision-making in relation to the treatment. And there is a bit of concern. So the answer for me would be no also. I don't think the bill covers your question. But I do think joint collaborative decision-making is going to be absolutely critical, and I think it's a retrograde step in relation to the bill, in relation to moving towards a treatment medical model.
And maybe just add, if I can, that, you know, sometimes treatment is a secondary issue to what people really want addressed in the first place. So often people will attend a service and they're looking for support with housing or support with benefits, and then once they build up that trust with the service that's been able to support them with these things, then they consider other potential positive changes in their lives that could be access and treatment. So the way that we've got our services kind of back to front in terms of that engagement piece. So really we should be encouraging people to attend for a variety of reasons, and the prescribing part or the engagement in other treatment services is a secondary component to that as well.
Notwithstanding what the panel's already said about what the bill does and doesn't do, does the panel believe that there is a way to amend the bill as it is to reflect some of those things that you've just spoken about, or enhance some of those services we already have? Or is it actually about putting effort into enhancing and promoting the services that we already have? And I wonder if I could go to Tracy first this time.
Yeah, I think if the bill was to go through in its current form, SRC would be looking to address the imbalance of power in relation to that joint decision making. But I think, going back to Kirsten's original point, I think there is some work we still have to do in Scotland. We wouldn't need this bill if we had quality, accessible treatment options available for people in Scotland. So for me, yes, there could be amendments made to the bill, but the fundamental issue is, for Scotland, is that we need to be working with what we've got in terms of the treatment systems that we have to make them more accessible for individuals, families and communities. Gillian, thanks.
Okay, thank you. I'm not sure if anyone else wants to come in, convener.
If I could just add that for the avoidance of doubt, we are quite clear that we do not feel that a legislative process is the right way. So it would feel disingenuous of me to make suggestions around amendments to a bill that we just wouldn't support.
And our view is the same at Scottish Families, that, you know, it was in our formal consultation response, so it's not any great reveal today, that we don't support the bill in any form. We are absolutely all on the same page about there being issues with the current system. We've mentioned already a number of things that are in place to begin those improvements, but that journey is nowhere near finished. But the bill, in our view, just diverts attention and resource from the changes that do need to happen.
That's great. Thanks, convener.
Thank you. Can I just ask as a follow-up then? There, just, you know, you were talking about resources. So would you feel that as an organisation that the resources that would potentially be put into this bill were it enacted would be better placed bolstering services, some of the issues that you've raised today of advocacy, etc. And other issues that play into people accessing services like housing, like benefits, that would be more beneficial in the long run.
Yeah, well, as you'll know, the financial memorandum quotes estimates of 28.5 million to 38 million, I think, just for the kind of treatment changes alone. I'm not too sure if that money's already been identified. I would have lots and lots of ideas for how that money could be spent to improve the system. But even with the existing system we have and where resources are currently, we need to look, in my view, at a fundamental redesign of that. You know, almost all of our resource is locked into NHS-led treatment services, which are not what people ask for. And we talk all of the time about listening to lived experience and being person-centred, but people do not want to engage with NHS services. And also, to be honest, the staff don't particularly want to work for them either. So I would like to see a fundamental service redesign which really does build much more of a whole system around, obviously, the third sector, statutory services as well, families, communities. You know, we need to put money where people want to engage, not where it's traditionally been invested.
Brian Whittle.
Thank you, Convener. Good morning, and can I just say thank you very much for your candid views on this particular topic. But I think for me, you were talking about the need to the issues with the bill and the need to put money where it's most needed. I've been in this Parliament nearly a decade, and this topic has been at the forefront of this Parliament for nearly a decade. And all the changes for me that have been made have all been negative. Do you not see that potentially the bill is forcing this Parliament to consider the way in which we look at addiction, the way in which we treat addiction, and the way in which we fund addiction or addiction services, forcing the Parliament to change? And potentially the bill has that ability to focus that attention that seems to have been missing for all the time that I've been in here.
I think it may be forcing Parliament to change and have a conversation, but going back to my original point, just because there's a legislative framework in relation to this does not mean that people will get access to treatment as and when they require it. So there's a fund, and I know this is a members' bill and it's quite narrow, but that for me is a fundamental flaw in the bill. Addiction, complexities, and the impact this has on individuals, families, and communities is not narrow. It's very broad, and I think for me, Brian, there is an issue around how we are funding currently the services around, and you said we've had a lot of discussions in Parliament and nothing's working. If you look at the work of recovery communities across Scotland, that is working. But the difficulty right now is most of the money is going into treatment. But if you look at the work, thousands of volunteers and a weekly basis supporting thousands of individuals with thousands of hours, we've done work around this. There is a huge amount of work, positive work happening to save people's lives. But our focus is on treatment. We need to move some of the money across the system. And we need to be supporting and valuing recovery communities, lived experience, and everything else we need around treatment. So, yeah.
And I very much agree with that. I very much agree with some of the best impact that's happening is in our communities. It's unseen. Very much around those third sector organisations who have, statutory services are not, many of those caught in addiction will not cross the lines of a statutory service, but the third sector. But the reality of what's happened over the last decade is those third sector organisations who are having an impact at the front line are being starved of investment and that ability. And I think that for me is something we have to do something different, and that's why I'm asking whether this bill is focusing some attention.
I'm so sorry. That's an issue around commissioning and how we commission human rights-based services at a local level. So there's a critical role here for health and social care partnerships based on local need, based on the evidence base, and that's an issue around how we commission services locally rather than the legislative framework that we need around a bill. So I think that could be addressed without legislation.
I guess there's another major issue around data and reporting and this absolute emphasis on continual data collection, which has taken services away from being able to deliver quality services as well. So there's so much focus on collecting all of this data without the focus, with the focus then being taken away from service development and improvement. So rather than using our data for performance management and reporting, we should be using our data strongly for service improvement. And a lot of that comes from fully embracing and involving people who use substances in the service design and delivery, but also getting that true raw feedback from what's actually happening locally and what their improvements are that are needed. I would disagree with the comment that nothing's improved. I think Scotland's drugs policy direction and intent is something that's welcome. You know, there are definite positives there. The major problem is the lack of urgency around it and the need to fully embrace that across the country. So more of the things in more of the areas is really what's required, and obviously that comes with more resource.
If I could return to your point about maybe your frustration or disappointment sitting in Parliament, not seeing the changes that we all want to see, that's something we really feel deeply, you know, and I think, following on from what Kirsten is saying, you know, we're actually tripping over very progressive legislation, policies, strategies, documents around alcohol and drugs, not only in relation to England, but in relation to just Scotland standing in its own right. And yet everything that's written down is not what's felt by families and communities on the ground. But that doesn't mean we need more legislation. And I think that's what we keep sort of tripping up on this and just layering and layering on more paperwork, if you like, writing down more of the things we want to do. We really need to get that laser focus on what is happening around implementation on the ground. And a lot of that comes down to where resources are, as we've touched on, but also the culture within our public services. And I'm sure those are themes we'll come on to.
Just to say as well, Scotland has no shortage of inquiries, evidence gathering sessions and recommendations that have been made year after year after year. So yeah, we absolutely share those frustrations about you know, these things not being actioned in the way that we would like to see. Yeah, I'll leave it there. Thank you.
Joe Fitzpatrick.
Thanks very much, Kavina. Morning all. Good to see you all. I think one area that we all agree on, whether you support the bill or don't support the bill, is that in order to be successful in this area and I guess other areas of health, we need it to be person-centred. So I think you've all touched on that to some extent, and I think but the committee is keen to hear your thoughts on whether the bill, the procedures in the bill, helps or hinders moving to a person-centred approach. I think I've kind of heard you answering that to some extent already, so I wonder if, as well as anything else you want to say about whether the bill helps with a person-centred approach. If it's not this legislation, then what is it that helps us get to that point of making sure that the care is person-centred? But Tracy, you've talked particularly about that imbalance of power within the system, so do you want to go first?
Yeah, I don't think the bill in its current form covers that, to be honest, and it's not just about a person-centred approach, it's about a trauma-informed approach, it's about joint decision-making, it's about choice and control, it's about access to services, so there's not really much more to add apart from to say that ultimately right now, in relation to the bill, it doesn't touch on trauma-informed practice. We have the NEST work that's going on. We have a range of different work streams going on around the MAT standards, access choice, access to rights, access to independent advocacy. So right now in its current form, I think the bill hinders that, and it's very narrow in its focus around joint decision-making.
Stira?
I think at the fundamental heart of any person-centred care, there is that relationship of trust that's built up between the person providing support and the person seeking support. And I think, again, the bill does kind of misappropriate that language of rights and focusing on individuals, because it just cements in that power imbalance that's already there. There are already very good person-centred documents supporting any NHS patients. The Patients' Charter, obviously, and there's a campaign that's running, it's okay to ask. So we're encouraging patients all the time to recognise the rights they have as NHS patients. And this bill doesn't add anything to what's already there. I think the other thing that's important to flag in terms of that person-centred approach is it takes time to build up those positive working relationships. And yet in the bill, it's like there's this event of a diagnosis and then this other thing happens. And, you know, working with people who are concerned about their alcohol and drug use, that's a process that should go on over a period of time. It's not a kind of one-off meeting, you know, where then something's written down and enacted. It's a much more, it should be a much more fluid and ongoing relationship.
Thanks.
Add that, you know, people tell us time and time again, people who use substances, that the key thing for them when they're accessing a service, what makes or breaks it, is that relationship with their worker. So you could have like an all singing, all dancing service and one that had very little resource, and actually, you know, it's down to those key relationships where people feel like they're being heard, that their views are being listened to and acted upon. So we would be concerned that legislation like this threatens that therapeutic relationship by creating bureaucratic processes like written information about treatment decisions, formal second opinions, and creating that adversarial process rather than that collaborative one.
That's really good. I think you've kind of probably answered the second part of where I was going to go, and I think if I ask anything more, I'll be moving on to the next person's question, so I'll leave it there, Convener.
Thank you.
Thanks.
David Torrance.
Thank you, Convener. Good morning, everyone. Can I put on record I'm a trustee of Fife Alcohol Support Services? Can I ask, does the bill include adequate provision to ensure individuals seeking treatment have access to advocacy and support throughout the process? No. That's yours.
I think that's something, I think all of us have kind of touched on it as well, that, that's a key thing that's definitely missing, and something that's really important in the sector, and something that has been developing, I would say, a lot over the last few years in terms of people's access to advocacy, and more emphasis around that, particularly with the national mission funding. There was some more emphasis around it. I mean, obviously it's still not enough in terms of what's available, but you know, it is an important aspect, and it's completely lacking and missing from what's been described.
I think in an ideal world, we wouldn't need advocacy, would we? Because services would be person-centred, trauma-informed and all those things we want. But we know through our work with My Family, My Rights, which is a self-advocacy model, families use like warlike language when they're talking about engaging with not just treatment services, but various public services. You know, they talk about sort of, you know, going in armed with information and battling with services. It's really sort of violent language. So that language suggests that it's not a level playing field where everybody's respectful and people's needs are being met. But we know where we are providing families with learning and information, and also useful kind of models and templates like the FAIR model, where they can, you know, write down what are the facts, the analysis, identification and review and so on. It doesn't take a huge amount to really help people access their rights and understand their rights, but you do need to do something. It's not going to happen automatically.
Thank you for that.
It's okay, sorry, just to add, to reflect on what Justina just said there, we have similar conversations with people who use drugs, although theirs is more in a risk ethos. So we know that treatment is a protective factor, but a lot of the time people comment to us that I might risk going back and accessing treatment again. So they see it as a risky process to go and try and engage with a treatment service. That's obviously the complete opposite of what we're trying to achieve for people.
Obviously, the Charter of Rights we started to draw out the real importance in relation to independent advocacy. So I think there's a massive opportunity in relation to the Charter of Rights around this space.
Does the bill effectively address the needs of family and carers supporting individuals with alcohol or drug problems?
Did I just start with this one? I think this is the bit of the bill that has caused most anger and frustration and disappointment for families. When the bill was in its very first form a few years ago, myself and a colleague met with Douglas Ross, who was leading on the bill at that point pointed this out to him, he was very understanding, and our interpretation of that meeting was that, you know, there would be corrections made. He very much recognised that that was an omission. So you can imagine the reaction when we saw the bill as presented today and saw that families are not even mentioned once. And I like to play a little game with myself just to see how family-friendly different documents are, which just word search basically. So the bill as presented mentions treatment 57 times, patient 37 times, health professional 16 times, recovery 14 times, rehabilitation 5 times, family 0 times, carer 0 times, relative 0 times. It doesn't mention advocate or advocacy either. So you can see in that setting, it flies in the face of all of the other positive written commitments that have been made around families in rights, respect, recovery. There's a national whole family approach framework, as I'm sure you know, as well as other documents like the Promise and, of course, the Charter of Rights, which is for people affected by substance use, including families, and families were deeply involved in that process. So I've probably got nothing more to say on it, but it's ridiculous.
I won't add a lot because I think Justina has said it all, but I suppose for me there's a broader policy context in relation to this. So a lot of the work that Public Health Scotland have done around the evaluation of the national mission and the role of families, the Audit Scotland report, the People's Panel report. So I think there's a lot of evidence around how disconnected and how families feel disengaged in this, not just in relation to the bill, but more broader in that policy context. So just to add in relation to that.
Just agree with comments others have made.
I have no further questions.
Thank you. Paul Sweeney.
Thank you, Convener, and thank you to the panel for coming today. I want to turn to quality of services, service standards and reporting mechanisms. I would like to ask the members of the panel what impact could the implementation of this bill have more broadly on the quality of services and treatment provided to people with alcohol and or drug problems? I'm happy to take any order that anyone wishes to start.
So just for the risk of repeating myself, we don't believe that a legislative process would improve the quality of services. So the comments that I'll make will be around how we see the improvements that need to be made in terms of treatment. And there are a raft of things such as better choice, different options available for people. A large part of this, though, is also the support to the workforce. We have a workforce that is under-resourced, under-supported, undervalued, and also, often running with exhaustive caseloads of people. So, of course, they're not then able to provide the quality of care that they would like to provide to people when you've got some people with 90 people on their caseload and, not able to spend that quality time with people to address their needs. I think the way that we deliver and design our service needs to be fully led by and supported by people who use substances and those with lived experience. And also look at different models of service provision. So we're quite fixed in the way that we've been delivering things in Scotland. And this, over the last almost 5 years of the mission, it's been a real missed opportunity not to fully address those structural issues around how we deliver our services. So that's something that really needs addressed going forward. Stigma, of course, needs addressed at all levels. And I think whilst I'm saying that we absolutely need the views of people with lived and living experience, we also have to be really mindful that some people's experience doesn't necessarily or automatically challenge stigma. And we have to be cautious of that in terms of the views that we amplify and how we hear those to ensure that we're not inadvertently stigmatising people who use substances who already face enough shame and stigma as it is.
Yeah, just to add in relation to the workforce development piece that Kirsten had raised, I think what I'd also like to add is we also have a unpaid workforce in Scotland, tens of thousands of volunteers who are doing this work for free, although gaining relevant experience around assertiveness, building confidence, education, going into recovery pathways, etc. But I suppose for me, this is not just about the quality of services, it's not just about a paid workforce, this is about a workforce that is currently doing a lot of work and being unpaid in Scotland, and I think that's really, really important. In relation to your first point of your question, I don't think this legislation will improve the quality of services. I think that's about commissioning, it's about using the data, it's about looking at what people need locally, and it's about recommissioning services in a human rights-based way locally.
When we spoke with family members and family support workers from our own charity and partner charities about the bill, that was one of the real concerns that they had, is that this kind of pressure to come up with this treatment determination from this kind of quite limited list within and provide something within a very tight time frame would actually reduce quality and choice of services rather than really opening up the conversation to what people need over a period of time. And there were particular concerns about, what really is the choice in like a remote, rural or island community? What's the choice for some of our population groups, like women with children? It just felt that actually it was really narrowing everything down, and the NHS boards would be under this legal duty to provide something, so they might just provide anything to kind of tick the box of meeting the bill's requirements rather than providing a quality option.
That kind of helpfully moves on to my next question about unintended consequences of the reporting mechanisms as currently drafted in the bill. You alluded to some there. Could you maybe expand on the point about potentially unintended consequences?
Yeah, I think there's lots of unintended consequences, and I think that as we've reflected, we've all got concerns about the state of treatment, care and support services, but that doesn't mean that the bill is going to make things right. So I probably don't have much to add to what I've said already, but I think, for families, they were quite cynical about whether this full range of options would be offered. We support families in 32 different local authority areas, urban, rural and island, from all different kinds of social groupings. They don't have all of these options for their loved ones on the doorstep. So what would NHS boards do? Would there be arrangements with neighbouring boards? How would that work when there's actually limited provision of most support in any case? So yeah, it was just sort of ill thought through really in terms of what is available.
I just wonder if any other panel members have any comments to make on the adequacy of the reporting mechanisms in the bill and potential for unintended consequences.
I think from an SRC perspective, what we do have in Scotland is a number of data systems that don't connect, don't join up and don't let us see the cradle-to-grave picture in relation to the journey that someone goes through. So an unintended consequence for SRC in relation to the bill is actually how much more data are we going to be gathering in relation to this bill? And what does it mean? Because currently, right now, our third sector services data systems don't connect with NHS. Our NHS systems in prison don't connect with local communities. And we're gathering a lot of data in Scotland. Is it the right data? But actually, what is it telling us right now? So for me, an unintended consequence is we actually may end up with more bureaucratic, complex data systems, which takes us away from frontline delivery, and Public Health Scotland have been really clear in that in some of their evaluations. Frontline staff are saying we don't want to gather more data, we want to work with people alongside them to support them in their community. So that's a massive unintended consequence for me in relation to data and how we're joining that data up to see the big picture.
I think the Scottish Drugs Forum had mentioned its written submission about the risk of gaming the system. I just wondered maybe if you could maybe elaborate on that as a potential unintended consequences you mentioned in your written submission.
I think we see this not just in terms of the bill, but we've seen this in many policies, processes over the years. I mean, my background's mental health nursing, working in a drug treatment service, and I was there when the HEAT standards were originally introduced, that people had to be within treatment within 4 weeks, 3 weeks, 4 weeks. And what you saw there was, to manage the capacity, people were ticking the box that folk were in treatment within that period because they were getting motivational and preparatory work, which I don't think anybody would really consider as treatment. But these are obvious things that happen when services can't meet the capacity and can't meet the demand. We've seen it with the MAT standards, where we've got all this local reporting, the pressure to report and to be seen to be doing well and to be performing overtakes that sort of need to really see what the raw issues are in communities. And we've done a lot of peer research work with some ADP areas around gathering information about the MAT standards to see if they're actually being implemented in the way it was intended. And what we see is, from the areas that have the peer research approach, is that we get the reality of the situation, and things are far from perfect. But until areas are empowered to be honest about what's not going well for them locally, and to be able to work on that, until whilst we're still in this position where we have to report and be seen to be doing well, we're never going to address the quality of these services. I mean, you walk through an airport and you've got those little machines that you can say whether you had a good service that day or not. Like, if we were to implement every time you'd accessed a service, if you were able to give immediate feedback on how you felt that service had been treated you that day, or what experience you had. These are the things that we really need to focus in on, people's true experiences of what these services are like. Otherwise, they'll never improve.
Paul, can I just come in very quickly around unintended consequences? I think what we need to be really careful of is more resources going into the treatment end. And we've seen that in relation to the MAT standards. We've seen a huge amount of resource and money going into treatment, and actually less money going into all the broader recovery-orientated systems of care elements that we need, that we know keep people well. So that's just another unintended consequence, I think, that's important.
Okay, thank you very much.
Thank you. Sandra Skohani.
Convener, a declaration of interest as a practising NHS GP. Kirsten, you spoke of data, and the one that really matters is the 1,172 drug deaths that we had in 2023, and at 27.7 per 100,000. That's 3 times higher than the next nearest country, which is Ireland. Also, the 1,277 alcohol deaths that we had. And we can all agree that these levels are disgracefully high. Justina, you spoke of families going into battle armed with information, and how this bill could be a retrograde step. Does it not seem important that families armed with information would be able to go into this battle that you speak of, which is what is happening right now, with a right in law to get treated?
There's actually no mention of any rights for families within the bill, so families have no right to be involved in any of this process whatsoever. That's in contravention of the Carers Act, where carers have got the right to be involved in decisions that affect them. So, as I said to the previous question, to exclude families from this entire process is contrary to every other bit of carers legislation and much of the substance use legislation.
Into amendments into the next stage of the bill. So if that was an amendment that was put in, would it, going back to my question, would it not be important for families who you say go into battle to have that ability, to have that right?
But the bill doesn't add anything to what's already there. So we're already working with families so that they can understand their rights as carers, but also like the patient's charter, for example, the MAT standards. They are already going into meetings with all of this information. This doesn't add anything to that picture, and in other ways it undermines so much progress that's been made around trying to promote person-centred care and trauma-informed care.
Sorry, forgive me though. From the evidence I've been hearing, it doesn't seem like that is the case right now.
The change we want to see, though, is that public services recognise their role as duty bearers. Even trying to get a GP appointment just now, I'm not sure how many people say, well, actually, I have got the right to health, I've got the right to life, when they're having that negotiation, trying to get an appointment. So that's that kind of cultural shift that I mentioned right at the start that we need to see within services. There's nothing within that bill this bill that's going to achieve that change, where services recognise their role in upholding and responding to people's existing human rights.
Okay. So if we created a bill that said you, by law, would have to get a GP appointment in a week, would that not completely change the conversation that would occur with reception with GPs?
Thanks. I just wanted to add in some real sort of scenarios that have been brought to us from people who are using substances. So we meet with around 150 people every week across the country who share their concerns. We're able to feed back their concerns to alcohol and drug partnerships. And when we've been doing consultation around this bill and what that would mean for them and getting their thoughts, it goes back to it completely missing the reality of people's lives. So they put to us that if they attend a treatment service in often quite a vulnerable position, already feeling pretty disempowered, requesting a treatment that is declined by the practitioner, the healthcare professional as described, and the reasons given by the clinician, and then they seek a second opinion, which is already unrealistic for them. They've said, we probably wouldn't do that. We're already in a disempowered position. We just want some help. So they're more likely just to accept whatever's offered. However, if they did go on and ask for a second opinion, then that's a wait. There's no timescale in terms of how long they might have to wait for that. They go for a second opinion and it's the exact same process, just with another healthcare professional. Again, they're told, no, we suggest this, but you want that. So then all the onus is on that person to seek legal challenge for that. It's just so unrealistic in the position that people are in to be able to actually feel empowered to do that. The whole thing is around disempowerment.
Are people empowered right now?
No. Because of the way that our systems are operating. So the disempowerment continues. But there is no feeling among people that we've engaged with that this would improve the situation for them. In fact, would probably create more bureaucratic hurdles and again threaten that therapeutic relationship that's so important to them.
Okay. And now, admittedly, this is Alcohol Focus Scotland who have said this, so they're not available. So I will put the question to you. If you can't answer, that's fair enough. But in their evidence, they talk about how there is no clear way for individuals to hold public authorities accountable. What is the current way people can hold public authorities accountable? And do people know who is accountable?
Well, I've already talked about the implementation gap, and there is also an accountability gap. And I think most people, if they have an issue with a service, you want to resolve it there and then. You want to resolve it either with the worker you're dealing with or possibly with the manager. You don't really want to go through years of complaints processes, stage 1, stage 2, stage 3. I mean, never mind taking somebody to court. This is all just, it's beyond the resources of most people. But the change, what we're trying to emphasise here is the change that needs to happen is that interaction within services, where the service should start from the position of recognising the person is coming in with rights, and what can be done to meet their needs in that person-centred, trauma-informed way. We know that's, we've been saying, all of us have been saying that's not happening just now, but this bill does nothing to change that situation. And I think what we're saying is there's other things already in place or planned or that need to happen. For example, investment in advocacy, promotion of the Charter of Rights. These things need to be driven forward to get the change that we want to see. The bill is just adding another layer which is not going to resolve the existing issues in the system.
Just to echo, I think, what Kirsten said in relation to the work we've done around the bill, it was very, very clear from the people that we spoke to when they're in that place of vulnerability, when they're in that place where their lives are chaotic, the last thing they want to do is to go and see a lawyer and get legal redress around getting access to treatment. In reality, it doesn't happen. It's just not where people are at in relation to that. So what you'll find is, and people we've spoke to, is they'll disengage, which actually creates more harm. So I think it's really important just to emphasise that.
And during that whole process are at increased risk of death. Like, the more delays, the more processes, the more people feel disempowered, and the more likely it is that somebody would die from an accidental drug death.
Okay. Thank you.
Thank you.
Thank you. Thank you. Thank you. Thank you. There's one thing I wanted to touch on following Sandra Scalhani's questioning there was around this idea when you come in and request a treatment. Surely that's not quite correct. Surely you come in when you're requesting a treatment that the medical professional will suggest the most beneficial treatment for you, and just because that's not the treatment you want. You know, am I getting this wrong? That you, because the way it was framed was that you would come in and request a treatment, and that was the treatment you would get. Surely it's the medical professional's opinion in this, as well, obviously with a discussion with the patient. Am I getting that?
I think you would come into a service seeking support, wouldn't you? That's what you know, and that support might have one presenting need. But actually, through a good relationship with the worker, you would then uncover all of these other things that also need support. I think there are particular times when somebody might request a treatment. For example, if they're on methadone and they might have heard about Buvidal and want to change onto that, they might explore that. They might ask about residential rehab. Or, you know, so I think there are times when people have heard about particular interventions and they want to explore that. But they already have all these rights under the patient's charter to kind of, have options given to them to, ask for a second opinion, to have somebody at the appointment with them. So this isn't introducing anything new about that interaction.
Yeah. The sad reality is that people have been in and out of services often for years and years and years. So they've often tried a number of different types of treatments. So they've got really good knowledge built up about what works best for them and at different points in their life. So a huge thing that's lacking in the bill is around harm reduction. So, it very much feels, and certainly the feedback from people that we consulted with is that there's a really heavy abstinence-based focus around it as well. So the reality for people is that they need different things at different points in their lives. Sometimes people seek abstinence, sometimes they might seek prescription treatments, but people generally know what's going to work best for them in their lives. And of course, it's really valuable to have the clinician advise and given information about different types of treatment. Certainly there might be new treatments that people have been unaware of, such as the long-acting buprenorphine. So they will give advice, but generally people are quite set on what they would like to try. And actually, if we're denying that for people, they're more likely to just disengage. So, that's to consider.
If I may, from listening to what you're saying, that for me it just seems to me that the thing that's lacking is consistent relationship with carer, healthcare professional, whatever. But I think what you said, my worry is there's a danger there that what you want to try, if a medical professional thinks that that's not to your best, for the best of your health, I think that from what you were saying there, that you were almost saying that they should have the right to try other treatments. Whereas
be more empowered to be choosing treatments as well. In the same way that if somebody was at their GP for an antidepressant and they were having side effects and they wanted to try a different one, the options, though, in some other medical conditions are endless. We're so limited in what we're able to offer people with substance use issues that the options are so restricted already that, that's another thing for Scotland that we really need to be considering. So we've seen a massive shift towards people using way more stimulants than we ever have seen before. There is no medical treatments available to support people who are using stimulants. So a lot of people who are using cocaine as their primary drug, but also using opiates, don't even see the point in going to treatment services to get their opiate use addressed, because they know that their stimulant use is the thing that's most out of control. So yeah, there's not enough options as well for people.
If I go back to the line of questioning I was supposed to be on now. sorry, I was going down. I just wanted something I wanted to follow there. I really wanted to come on to sort of funding and resource allocation, if I may. I start with a really basic one around potential additional costs might arise from the bill's implementation that maybe isn't accounted for in the financial memorandum. Is there any issue in there that you see at all? Any additional costs?
I could reflect on that from the conversation we had with our family support workers. that, you know, they were concerned that actually the pressure to deliver a thing would not be able to be met by NHS services, so the NHS services would then expect third sector services to kind of pick up the slack. But the financial memorandum doesn't mention any additional funding for these third sector services. Also, there's no mention of funding around advocacy. We've already touched on that quite a lot. So I'm sure there are a lot of uncosted costs that would come along with this legislation, as always happens.
And just to add, there is no mention in relation to the funding that's required at the back end of the system around recovery, recovery capital, recovery communities, lived experience, recovery organisations that are a fundamental part of keeping people alive in Scotland. So there's no mention or cost attached to those, and they're currently underfunded.
Well, on that, I mean, my personal kind of, you know, passion is around that sort of that prevention, around that element in there, and the way the system works at the moment. You know, there's no funding for third sector organisations apart from going through statutory services. The ADP programme, they're the ones that pass on the funding to third sector organisations. Has there any work been done, do you think, around the sort of positive impact, not just on the lives of the people that are caught in addiction, but also the reduction in finances, the positive the would have, you know, ability to have on society? Is there enough work being done around that to understand that the positive impact, both personally and financially, to a system that works in the way you want it to work?
In terms of social return on investment, there's probably a range of different research we could look at in relation to that, but I know Public Health Scotland have been commissioned as part of the national mission to evaluate where the money goes. So I think there's going to be some findings in that over the next few months in relation to what that looks like. But and I'm glad you raised this, Brian, because ultimately what we don't have in Scotland, and SRC are doing work around this, what we don't have in Scotland is a clear picture of where the money is going in relation to recovery, in relation to recovery-orientated systems of care. And I know I'm mentioning this a lot, but it's so important. So we have the CORA Fund, the CORA Fund through the National Mission, who's funded a number of recovery grassroots organisations, but we know post-2026 that funding will end next March. So currently we don't know what post-2026 is going to look like, and this is the opportunity, I think, this year to really start to focus our energy not just in treatment but in everything else that we need to support the lives and to reduce drug deaths in Scotland. And I think going back to Sandish's point around the drug death stats, they're absolutely horrendous, and the alcohol related deaths. But what we're not recognised in Scotland is, I think, and having spoke to loads of people, hundreds of people across the country over a number of years, those drug deaths would be higher, those alcohol-related deaths would be higher if it was not for the work that is currently happening in our communities, by communities, to support this. And that needs to be recognised and valued. So I think there needs to be some focus on that part of the system, because I have no doubt drug deaths and alcohol deaths would be higher if it wasn't for the work in our communities right now.
Sorry, can I just add to that the comment that's important that Tracy just mentioned there is not the funding, not just for treatment, because the last thing we want to be doing is pitting different services, provision of care against each other, because the reality is that we need everything. So we need recovery communities, we need residential rehab, we need treatment, we need harm reduction, we need the whole of everything. You know, there's obviously some discussion around the lack of investment in alcohol-related supports as well. Massively important, massively under-resourced, but none of this stuff should be at the expense of the funding that's currently there for drug substance use, because we just don't have enough resource of that already. And on the funding thing as well, just to add into that, you know, it's not just about the level of funding, it's about the length of funding as well, which is a key issue in that previous point you made about the relationships and people having different workers, because services aren't sustainable when they only have 1 year's funding, and they're constantly in that cycle of short-term funding.
Another one of my bugbears. I don't want to get down that rabbit hole. But if I could just one more question here. I mean, in terms of what my hope would be is if the bill, albeit in an amended fashion, came through, the impact that would have on enhancing health services and probably forcing the positive way in which we bring the third sector into this. Because for me, to deliver the bill would require all of the services that you have discussed there, and would actually, I don't want to say force governments to properly fund the whole system rather than the way it is just now. Do you not see the way the potential of the bill would have to force that investment in the whole system, because that's the only way this works. I mean, it's scary to say that bad as our drug deaths are, it would be a lot worse for all those third sector organisations and all those volunteers that we all know about in our areas. Is there not? We need to force the issue here.
And on that, there's nothing in the bill that talks about that. The bill is all about NHS services and this kind of relationship between the health professional and, or not even relationship, the interaction or transaction between the health professional and the individual. There is nothing in the bill that commits to funding for other parts of the system. And our concern is almost the opposite, that this bill, if enacted, would suck up funding that's currently in that wider system back into NHS-led services, which, as I've said already, is not particularly the services people want to engage with or the services where people want to work. So it would almost have the reverse effect to that you're suggesting, in my view.
But my point is that's what's currently happening just now. It's not getting passed because all the funding just now comes through statutory services before it gets to the third sector. So that's my point, is that's exactly what's happening just now, and we need to reverse that.
I just don't see how the bill would do that, though, as it's, well, however it's written, there's nothing in it that talks about that whole system or multidisciplinary support or the third sector. So it's all about statutory services.
And I think there's just a broader point, and I do understand how the structures and systems work around where the money comes from, health and social care partnerships down to ADP and down to commissioning, but there is a number of discretionary funders in Scotland, Cora, Robertson Trust, who are actually funding a range of services across the country, so they need to be brought into the mix in relation to what investment, the whole total investment is in Scotland in relation to how we change our treatment system. So yes, more services would come through the statutory route, but there is a range of services all across the country being funded with a huge amount of money not coming through that route, Brian. So it's just to make sure that we can broaden that out, I suppose. And just quickly, I think there's something around the justice system in this, because I think the bill, if I was going through the process, I got access to treatment through this bill, I then got put into prison. There's a question around whether that right follows me through the justice system and back out, and I don't think anybody or any committees touched that, so I think that's important. Will that right follow me when I get put into prison and back out again? So I think that's just a caveat that I added in very sneakily. Sorry.
Maybe just to say something a bit broader around that sort of wider resourcing and focus. Like, we're always going to be firefighting these issues until we properly address the root causes upstream around poverty, deprivation, trauma, lack of opportunity, and really starting to look at longer than a government term process. So something that's like a 15, 20-year strategy for all of this across all the portfolios that have been mentioned. Because we're always going to be in this position. I mean, we always, of course, are going to need some resource for the emergency end and the sort of firefighting stuff. But my God, when are we ever going to look at that sort of broader picture and really address that upstream work?
I shall leave it there on that note.
Thank you. And I think Sandesh Gohani has a supplementary.
Yes, thank you, Convener. Tracy, I'm glad you know how the funding happens, because I struggle with it and it's very opaque, and the way the money is distributed, I don't think we are able to audit very accurately as well. And we spoke about the third sector here, and we spoke about communities. And in my region of Glasgow, award-winning services are being cut. And if you look at NHS Grampian, which has now been escalated to level 4 due to finance being one of the reasons, we're going to see further cuts occurring, and one of the easiest places to make the cuts seems to be within drug and alcohol services in the community. So my question really is, how can we protect these community spaces which do amazing work, especially those people who know individuals, actually know them, know when they're starting, know when they're stopping, what's going on, and being able to intervene?
Can I just maybe say, like, why is it that drug and alcohol services are easy pickings in terms of when it comes to cuts? Who are in those leadership positions that are not considering the range of areas across their remit? So the reliance is also, as well as on national decision makers, but on local decision makers as well, to stop stigmatising and discriminating against people who use substances, because at local level those decisions should not be easy. In terms of cuts to drug and alcohol services. So, I mean, we can do the work at our end in terms of empowering people to know their rights, but we know that people in vulnerable and marginalised positions are the least likely to complain. They're the least likely to go through complaints processes and services. And yes, they might have some independent advocacy to support, but you know, there's still that disempowerment there. So I would like to look at how we address that in local areas in terms of decision-making processes about it not being an easy option. Yeah.
Yeah, I mean, I think it's difficult as a third sector CEO to sit there thinking, well, you know, we need to evidence impact for absolutely everything. We need to account for every penny that we spent. It's all, you know, published there, and there is an element of, it's not always transparent where all the investment in public services has gone, and I think we're finding that with the National Drugs Mission. And as Tracy said, there is work going on by Public Health Scotland to look at cost-benefit analysis. But I think that you talked about, you know, evidence-based services that are closing, and it feels that, you know, we're not just proving that things work doesn't protect you. And I had the privilege last week of chairing the Scottish Community Link Worker Network conference, not as in terms of any declaration of interest. They just asked me to do it, and I was happy to oblige. And I mean, community link workers are a workforce who are the absolute unsung heroes, I'm sure you know, of the health and social care system. There were people actually there on that day who had already lost their jobs, but they still wanted to be present at the conference. And almost everyone in the room was on year-to-year arrangements that were so really nerve-wracking for them, really. So it feels that no matter what the third sector does to prove its worth, to prove the return on investment, it doesn't protect us at all. And when push comes to shove and budgets are being cut, we're the first victims of it, definitely.
Yeah, just to add, it's really interesting nationally in the meetings I sat at that the impact of drugs and alcohol cuts across every single thing that we talk about: child protection, adult protection, community planning, mental health, and actually the harms associated, if we actually fundamentally looked at how we fund that, would have an impact on a range of different areas across the country. Adult support and protection, child protection. We know the number of cases in Scotland where there's drug and alcohol issues around families, the additional cost that costs to social work, the additional cost that costs to health, to child protection, the children's hearing system. So actually, if we looked at this in a different way, to say, well, actually, fundamentally, drugs and alcohol harm cuts across every single element of our community. If we looked at it in a different way, I think we'd have a different outcome.
Just to touch on Justina's point there about demonstrating the impact, you know, what's happening in Canada and the States is really concerning, because it doesn't matter if you show the phenomenal impact of some of these services that we provide. It's when it's up against moralising and ideology that sometimes has the bigger impact. So it's really scary to see what's happening in terms of some of the cuts to services in Canada and the States based on who's in administration and the impact that that's having on communities, and the rates of deaths just rising because of that approach.
And just lastly, I wonder if there's a way that money comes into justice, mental health services. I wondered if there's a way that we could really stop the siloed approach in relation to how funding comes into the system. Because if we looked at this across if you think of the money coming into the justice system, a lot of people in the justice system have issues around problematic substance misuse. A number of people in the justice system have mental health issues. So if we looked at a different way, because there's a lot of money in the system, but it's siloed. And we know, in relation to the Hard Edges report that there's thousands of people in Scotland being bounced around 5 or 6 different systems. Justice, mental health, addictions, domestic violence, homelessness. They're all going to the different services. So if we could find a way, Sandish, in relation to how we get the money from a national level to local level, and we brought some of that money together, I think we could have a really different thing and a change in Scotland about how we do that. And we need you guys as MSPs to start having that discussion, I think. So the challenge is back to you, I would say. But I'll work with you, if you like.
Can I ask then, just as a final question, given the number of areas that you've covered in response to Sandish Gohani's question, and the number of really important issues that you've raised, does this bill in any way address those issues that you've vocalised?
I think I've made quite clear that no, I don't think the bill adds anything at all.
Tracy?
Currently, no.
We're still not convinced that it's the right approach to go down a legislative path.
Can I thank you for your attendance today? And I'm going to briefly suspend the meeting so we can have a changeover of witnesses. Thank you. Welcome back to the Health, Social Care and Sport Committee as we continue scrutiny of the Right to Addiction Recovery Scotland Bill at Stage 1. The committee will now take oral evidence from a second panel of witnesses comprising representatives of third sector organisations. And I welcome to the committee Lee Ball, Director of Addictions, Salvation Army, Graham Callender, Policy and Public Affairs Lead with you, Jan Mayer, Practice and Innovation Lead, Alcohol and Other Drugs, Turning Point Scotland, and online Anne-Marie Ward, CEO of Faces and Voices of Recovery UK. And we'll move straight to questions, and Elena Whittam.
Thanks very much, Convener, and thanks to the panel for joining us this morning. I set out my questions to the last panel round about actual rights, and I'll do the same to yourselves. I think it's important that we do realise from what we've heard and what we know that people are not able to access a lot of the time the treatment that they think is going to work for them in a timely fashion. So I'm wondering whether the panel believe that the extent of the provisions in the bill will ensure that the rights of people who use substances are realised. And I would maybe want to perhaps start with Anne-Marie, who joins us online, if I can do. Anne-Marie?
Hi there. Hi, Elena.
Hi.
Hi there. Thanks very much for the opportunity to speak today. Yeah. As you know, the organisation that I work for is an organisation that's rooted in lived experience, and it's absolutely grounded in evidence. It's also built from grief and hope and action, as I'm sure you're aware of in the last few years. And we've quite clearly seen that the rights that people are supposed to have are not being, in any way experienced by people when they first come forward for treatment. They can also be in the system for, 20, sometimes 30, and in some occasions even 40 years. And in all of that time, their rights are not being experienced. So I'm here today not as a theorist or a policy bureaucrat, but as someone who has walked the path of recovery and who stood beside thousands of people trying to do the same in Scotland, many of whom are no longer with us. And the Right to Recovery Bill is not abstract to me. It's not an academic exercise. It's a matter of life and death for many people. So what I've learned from our advocacy work over the last 3 years is that the system is not just overwhelmed. It's actually very obstructive in many cases. And we know this because we've stood toe-to-toe with people when they've tried to access the treatment that they know will help them. Our advocacy staff team has just one and a half people, and it's supported 123 clients and over 40 families, over 25 local authority areas in Scotland. And we've fought through bureaucracy, tremendous bureaucracy, to secure the right to the treatment that the person's asking for. And in many cases, in fact, but only in 22 of those 123 cases was it for residential rehabilitation. Those were the only ones that we were able to secure, despite probably 2/3 of those 123 people asking us for it. We've prevented homelessness and helped people resolve their benefit chaos and challenged illegal and discriminatory decisions across the sector. So if you're asking me if people's rights are being adhered to, I would say unequivocally no. And what's stopping people from getting that help? It's not cost, and it's not clinical judgment, and it's not capacity. It's culture. It's a culture of gatekeeping, of unaccountable panels, of risk-averse funders and quangos more interested in optics than outcomes.
Thanks very much for that, Anne-Marie. I'll open up to the rest of the panel, and I think that following on from that line of thinking round about people are not always able to realise their rights, and that does come down to those issues as narrated by Anne-Marie. I'm wondering whether you feel as if the provisions that are within the bill will ensure that people are able to realise their rights. And I don't know who wants to start. Graham, thanks.
So thank you for the opportunity to share our sort of kind of feedback and evidence in terms of relation to this bill. And, you know, with you in Scotland, are a national drug and alcohol charity, and we support over 15,000 people per year at various stages of their treatment journey and their recovery journey. I think what we have seen over the years is, I think, you know, when we looked at the bill, like, I think we get behind the kind of intent behind the bill about trying to make things better for people. I think where we come from is the practicalities, right, where we see people before they even get to treatment, and there are barriers to treatment. We are not sure if this bill, as it's currently written, will be the answer to that solution. So I think that's not about the intent or the rationale behind the bill that we have any objection. It's actually about how do we make sure that it actually happens, because I've been in this sector for 20 odd years, operations, frontline, more recently policy. I know how difficult it is for people to navigate, but I'm not sure, like, the bit that Bill sort of kind of focuses on, which is about, you know, access to residential treatment and access to community detox. These are really important, but most of our job is about trying to get people to those things in the first place, and what we can't see is whether this bill is able to address that, or, you know, maybe with more consultation or more adaptation it could be. So I think, you know, as I said, we're broadly supportive of the intent and the rationale, but we're really concerned about some of the practical sort of kind of implications of that.
And Dan, from a Turning Point perspective?
Yeah, I would echo that exactly, really. We are completely in support of the intention of this bill. Like Graham, our organisation works with many people who aren't even getting into treatment yet and aren't ready. We do a lot of assertive outreach. We're working with overdose response teams and drop-in harm reduction clinics. And yes, people need access to treatment. I'm not convinced this bill is the right way to do it. I'm absolutely behind the intent of it. I'm not sure it's the right way to do it. And I guess a slight worry for our organisation is that it might be a distraction. Many of the people who use our services across Scotland were involved in the consultations with the National Collaborative for the Charter of Rights, which has come on a long way and seems to do a lot of the same things of this bill, but without perhaps some of the problems. It seems broader, actually. The Charter of Rights seems broader. And so my slight worry with this bill, or big worry, is it might be a distraction from something that we're already a long way down the line of, that's had a lot of consultation with people in the system.
Thanks very much, Jan. And what about Lee from Salvation Army perspective?
First of all, thank you for giving us the opportunity to speak into this today. Like I think Graham and Jan, we work with an awful lot of people who haven't even reached the door of treatment. Over the last 5 years, we've worked with approximately, I think, almost 3,000 people who have arrived with the Salvation Army in services within Scotland with a drug and alcohol problem that can't or won't access treatment. Now, there's a number of different reasons behind that. I think some treatments are not designed for people to be able, are easily accessible. I think a lot of clients who come to us have poor prior experiences of treatment or healthcare systems as well, so they're very reluctant to engage. We do support the ability for somebody to have their rights enshrined. We do welcome the fact that there is the right for a second opinion, and for people to justify a denial of what is the preferred type of support that the individual wants. That all said, that is going to come with a huge amount of responsibility on the entire system as well, and there needs to be the understanding that the system as it currently stands is so stretched. Workers are so stretched at the front line that in order to support the person to enact those rights, that is going to have to be resourced as well.
Thanks very much for that. And I suppose Jan's already touched on the second question I had, and that's around about how, you know, to what extent the bill will complement or indeed could conflict with the Charter of Rights for people affected by substance use. And I guess I have a concern about the fact that we don't have a Scottish Human Rights Bill on the horizon at the moment, and that was what was to underpin the Charter of Rights. I saw, Anne-Marie, your hands went up, so I would be quite interested in hearing from yourself as to how you think it could complement the Charter of Rights versus conflict with it. Thank you.
Okay, with respect, the claim that this bill is impractical or a distraction is just wrong, and it's deeply cynical. It's not a good faith concern. It's a strategic deflection from organisations who are more worried about control and optics than outcomes. Those raising this objection are not coincidentally the same organisations that are currently commissioned by the Scottish Government to provide treatment, and they are the status quo providers, the first two speakers who spoke. They're funded by a government entirely embedded in the existing hierarchy of control, and of course they're objecting. This bill threatens to shift power from them to the person seeking help. That's not a distraction, that's democracy. And the idea that the Charter of Rights is a better alternative is laughable. A charter is not enforceable. It's a poster on a wall. It's not a right, it's a suggestion, and it offers no route to challenge, no legal redress, and no accountability when treatment is denied. And we know this because our clients have been waiving these charters in meetings for years. Hell, we even created one, the UK Recovery Declaration of Rights, and still we've been told, oh, you're not really ready for detox, you're not really ready for rehab. Most of our clients have been silenced by the multidisciplinary teams. They're not even allowed to attend their own meetings when it comes to their future. They've had care plans that they've never seen, and they've been stuck on methadone for decades with no review, no reduction and no route out. Let me be absolutely blunt here. The people saying this bill is a distraction are the same people who have failed year after year to deliver access, transparency or choice. They are not neutral observers. To say that they are is ridiculous. They are institutionally and financially invested in avoiding scrutiny. And our advocacy service has worked with 120 clients. Not one single one of them had ever heard of the so-called MAT standards. Not a single one of them had ever been shown a care plan until we stepped in. Many were told explicitly that rehab was not an option. We only succeeded in getting them the treatment they needed by relentlessly challenging the system, and we were told a charter would be enough. That is not a distraction. It is a real mechanism of accountability. This bill that would change the Scottish treatment landscape. That's why they're saying it's a distraction and it's not practical. The question is not whether this bill is too ambitious. The question is how long will we keep prioritising the comfort of institutions over the lives of the people they're supposed to serve. This bill doesn't disrupt recovery, it disrupts bureaucracy, and that's precisely what Scotland needs.
Thanks, Anne-Marie. I'm going to open it up to the rest of the panel in terms of thinking about the work of the National Collaborative and the Charter of Rights. I share the concerns round about that not being enforceable the way that it was seen to be perhaps enforceable down the line with the Human Rights Bill. So taking that on board, do you feel as if the Charter of Rights could complement this bill as it's set out, or is there conflict? Because as it stands at the minute, people are unable to realise their rights in every instance. So I don't know who wants to start. Graham?
So, I mean, I think the bill as it was presented for us, and I'll repeat this, is that it feels it's a very narrow definition of what's classified as treatment in Scotland. And as a third sector provider who receives our money directly from local authorities to deliver recovery services on their behalf, is that we are not responsible for prescribing. We come up against the same challenges as that many of our clients do about wanting to reduce or accessing residential rehab. I mean, we advocate ourselves on a lot of these issues. Again, coming back to the sort of kind of bits of the bill, you know, we have always said that we are supportive of the intent of instilling that right in legislation. The concern that we have is about how is that going to be practically delivered? Because at the moment, you know, we've got this sort of Charter of Rights coming, we've got this proposed legislation as well, and the system is still difficult to navigate, and I'm not clear of whether this bill or the Charter of Rights, without proper consultation, collaboration and joint working, none of it could all fall down on deaf ears if it's not implemented properly. But what I will say about the Charter of Rights, it has felt a lot more collaborative in terms of it seems that the sector has come together to talk about some of these things. I think with regards to this bill, I think it's been a lot more challenging to engage in some of the key topics. And that's just sort of as a third sector provider, that's our observation. So it could complement, but I think there's still a lot of work to do with this bill, in my view. So.
Jan or Lee, do you have any other thoughts to add to that before I hand back?
I mean, I would just agree with Graham, really. I think I would much prefer to see that legal underpinning for the Charter of Rights. I think what I like about this bill it is the accountability. We want that accountability. We want that accountability not just for ourselves, but because, as Graham says, you know, we also work at the end of people who've come out of residential rehab and supporting them back into their communities. But I suppose the bit I'm worried about is where we're working with people who haven't even got near treatment services. We're advocating for them to get into treatment services. They're a long way from it. And this bill, because it focuses just on the treatment bit, it doesn't give them rights at that earlier stage, which the Charter of Rights does.
Thanks very much, and I think... Oh, yeah, on you go, Lee.
As well. When you mention accountability, I think I was in services yesterday within Scotland, and when you speak directly to the staff and to the service users in receipt of services, one of the things that they ask for is accountability because they don't feel that it's currently there. So I think we have to be concerned about almost tripping over different pieces of legislation competing with each other. What I think we need to always make sure that we come back to is the fact that there is an unheard voice quite often that doesn't even appear in treatment, that does need to have the ability to hold people to account for their treatment pathway before it even begins, yes, and what options are actually available to them. One thing that, while we are in support of many things within this bill, one of the things that we are concerned about is the omission of explicit harm reduction interventions within this as well. And people need to know before they walk in through the door that that is something that is possible and something that they have power or control over as well, and that they can hold services to account.
I think accountability and implementation are going to be big topics this morning.
Thank you. Anne-Marie, I believe you want to come back in here, if you can be brief, because then we've got other questions that we need to move on to. Thanks.
So let me respond directly to the accusation that the Right to Recovery Bill offers a narrow definition of treatment or is somehow confusing people because it exists alongside the Charter of Rights. This, again, is a completely disingenuous critique, and let's be honest about where this is coming from. The organisations that are pushing this line are not neutral players. They are the very institutions that have refused to engage with the bill's creators, they've refused to inform their own stakeholders and refused to distribute the myth-busting document that's been publicly available since 2022. 3.5 years, not one effort to engage with it. So when they're saying that, you know, the Charter was much more collaborative, they have not had one briefing session offered by those who are, you know, these people are claiming to be confused. Well, that's because they've not spoke to us and they've not engaged with us. If there is confusion, it's been carefully manufactured by omission, not by the bill. And let's be absolutely clear, this bill defines treatment exactly as it exists today in law under the NHS Scotland Act. It covers all recognised forms of treatment: detox, rehab, MAT, psychosocial interventions, harm reduction, day programmes, peer-led services. And if it's a legally available NHS treatment, it's included. And what the bill does not do and has never claimed to do is write poetry about recovery. It's not meant to be a feel-good declaration. It's legislation, not a campaign badge. It creates an enforceable right to access what is already supposed to be available. And by contrast, the Charter of Rights, the darling of the very services who have failed to deliver results, is non-binding. It has no teeth and it cannot be challenged in court, and it is at best a public service announcement. And at worst, it's a PR exercise there to distract from the fact that services still deny treatment, still refuse rehab referrals and still ignore lived experience until it's conveniently pre-approved. And let's talk about the idea that this Charter is more collaborative. It's not. It's simply been written by those people who have refused to collaborate with the drafters of the bill. There is no high-minded unity here, just politics, exclusion and turf protection. And let's be honest, the Charter has been embraced embraced because it asks nothing of the system. It requires no structural change, no reallocation of power and no uncomfortable scrutiny. That's why it's so collaborative. It costs nothing and it changes nothing, and the Right to Recovery Bill is not confusing, it's confronting, and it challenges a system that has become too comfortable with managed decline, and the people saying otherwise, they're not confused, they're just being challenged for the first time ever. So let's not pretend this is about clarity, it's about control.
Mr Whittle.
Thank you, Convener. Again, good morning to the panel. Just a very quick one. You discussed there about the bill not talking about, you know, the pre-treatment type working that's so important in trying to get people towards treatment. But would you agree, though, that to get if people we get those people to make that decision, that hard decision, that brave decision to seek treatment, and then not to get it, is incredibly destructive to that person. So I would ask you the question, because the bill is so explicit in terms of if you ask for treatment, you have the right to get it. Is that not important? Because the worry I have is people seeking treatment and then not getting it, and where that leaves them. It leaves them in a much worse place.
Can I speak to that? Yeah. All right. The idea that you can seek treatment, because the courage that takes to actively seek treatment is huge, and to have that courage or that need not met at that moment in time, it can absolutely be devastating, and that person will tend to appear somewhere else within the system at some point because of that decision that's made. One of the things that we're really concerned about within this is the definition of treatment and when it begins, because what we've witnessed is people actively seeking treatment but being held on a waiting list, and that quantifies beginning treatment in and of itself. So therefore, I think we need to be really, really clear about what is it that treatment means, because if it's treatment to get onto a waiting list for a rehab, if it's a treatment about waiting to get onto a method, those things can be devastating in and of themselves as well. So we need to be really, really clear, what does treatment mean and when does it truly begin, and when will those numbers be counted from that point?
Okay. Thank you. Thank you. Thanks, in the previous panel, I was asking about the requirement to have a diagnosis of an addiction. I'm interested to hear your thoughts about advantages or disadvantages on the bill's approach to requiring a diagnosis ahead of entering into all the different types of treatment that could be offered.
I think there are a couple of things for me in this. We're quite concerned about the idea of people needing a diagnosis. We think it's an unnecessary barrier. We think an awful lot of people don't actually want a diagnosis and don't need it, but they do need the treatment in its broadest sense. And I think I'm particularly worried about having a diagnosis of addiction, because there are many, many people across Scotland who have very serious problems with their use of alcohol, with their use of cocaine, but they're not physically dependent. And so the word addiction and a diagnosis of addiction, I'm not even sure one exists. I think it's substance use disorder is the technical diagnosis. It would put people off seeking it, where often people need to come and talk about their problems and don't want that over. And I'm not saying it's not a health problem. It is a health problem. It's a medical problem to that extent, but it's more than just a health problem. For many people, it's a social problem. It's related to community issues. And at the initial stage, a diagnosis can be a barrier to getting support. And as I say, I think there is a risk that we focus all our energies on those people who might be physically dependent because of the use of the word addiction, and miss out all of those people who are at risk of dying from their drug use or their alcohol use, at risk of serious harms from their alcohol use and drug use, but are using in a pattern that isn't physically dependent.
So, yeah, very similar. I mean, I think when we looked at the bill as it was introduced and we spoke to over 30 people within the organisations, half of our staff have got lived experience. We've spoke to, a number of our clients in frontline services and clinical staff as well. I think that was one of the key things that they did pick up about the diagnostic part, is that when I look at our services, people come to us because they need help. They're not going, oh, well, it's cocaine is the main thing, or it's this or that. It just could be a number of different things. And we don't wait for a diagnosis to happen before we start support, a lot of the time on this very same day that they present in our services. However, there are obviously occasions where you need to diagnose because people's lives are complicated and there are significant health harms that go along with it. And a lot of the people that are maybe at most at risk of overdose are the ones that may require a diagnosis, but there should be no delay in that. I think the other part as well for me is around the medical professionals element, and I think we would obviously need reassurance that how we upskill all medical professionals to be undertaking diagnosis if that's the route that we go down. Because not every health professional is at the same level. We were just chatting about it before we came in, is that sometimes we're in a bit of a bubble and I assume everyone knows what I know, etc. But actually, if you're working in a GP surgery, you've got a million different topics that you've got to juggle. So we need to be able to upskill medical professionals if diagnosis is the way to go down. And the last thing I just wanted to raise, which came directly from our clients, was about the need to be confidential and about the potential of addiction and diagnosis being on someone's medical records. A lot of people that we support are in work. They might have things tied to that they're worried about disclosing what's going on in their personal life, and they raise those concerns. So I think as the bill progresses, or if it does progress, that's one aspect that I think needs to be looked at carefully, because people have the right to remain anonymous.
I agree with...
Before you come in, Lee, I just think on that issue around, I need to remind everyone, I am a nurse and I have worked with people in recovery room and operating theatre who were people that were affected by harm from drugs and alcohol. And so I'm thinking about, as you're responding, Lee, does language in the bill need to change then in terms of, and what suggested language would you want to secure?
The term addiction is quite often a loaded term. And when we talk about a diagnosis of addiction, addiction is quite seldom the single issue. Addiction is a symptom of so many other things, and therefore to give a diagnosis on just that one thing, whilst not incorporate all the other social kind of biopsychosocial issues that are incorporated within that, I think is quite narrow. A diagnosis is a help or a hindrance. It depends on how it's used. So I think that's really, really important. But I think on the back of Graham's point as well, people do have the right to privacy. So the idea that this could go onto medical records is another issue. But the one thing that I would really, really ask the bill to consider, should it go forward, is this narrow term addiction, because addiction is a symptom of so many other things. And I know this question will probably come up over funding and different issues like that, but addiction is too narrow a word to be used for this. And quite often for some people, it's a very loaded term. It comes with stigma. It can come with an awful lot of negativity around it as well. Language defines the reality that we live in, so we need to be really, really careful about the way that we talk about substance use and the way that we talk about people who are using it as a coping strategy as well.
Okay, and just to be clear, and the protection of somebody's anonymity is really part of where the language around addiction we need to be careful about. So that could be something that could be amended, for instance, in the bill as it progresses.
Do you know what I mean? We work with so many people where addiction is a symptom of the point in time that they're at. This thing can increase, it can go down, it can move back. It's constantly a movable issue for an awful lot of people. So I think, therefore, to almost define it as one point in time, and there's the diagnosis, but that point in time, I think is really, really narrow. So we need to be careful about almost pigeonholing it just onto that one area.
Okay, thank you, thank you.
You wanted to give an
on
this?
Of course.
Hi there, let's cut through the noise here, guys. The claim that a diagnosis is stigmatising or a barrier is absolute nonsense. Every area of healthcare starts with a clinical assessment. Addiction should be no different. People don't die because they get a diagnosis, they die because they're denied treatment. Now we're hearing that staff aren't skilled enough to assess need. That's not a flaw in the bill, that's an indictment of the system. The same staff already prescribe methadone, assess risk and make decisions daily. If they can't confirm someone needs help, then what exactly are we funding? This isn't about ability, it's about accountability, and this bill makes services legally answerable. That's why it's been resisted, and if training is needed, let's provide it, but don't use workforce failings as a reason to deny people rights. The truth is simple, diagnosis saves lives, the right to recovery bill ensures people can act on it. Let's stop making excuses, please.
Okay, and can we make sure that our language is courteous throughout these proceedings? Thank you. Sanders Gohani.
Question of interest as a practising NHS GP. Just on the point of addiction being used as a diagnosis, we heard from the Royal College of Psychiatrists, and it was clear that perhaps the word addiction is not the right word to be used. And I'm sure Douglas Ross, who is the member in charge of the bill, would be looking into that. So if we were to amend this, I think, moving on from the question, if we were to amend this, because we need to say that you have something, not necessarily a diagnosis, but you can't, what is it that we should be saying, in your opinion, as a way to have the right to have a treatment? Is it simply you would like to receive treatment, or what exactly would you suggest?
Thank you for the question, Sandy. I think for us, it's always been about access, right? So treatment is there. We recognise, as an organisation, we have a full clinical offer in England, not in Scotland, so we understand the importance of clinical processes. And in certain circumstances, diagnosis is absolutely critical because there are other things that are going on, underlying mental health, underlying physical health problems. So we completely recognise that. But the reality of the system is that people can't get access to the system. It's not about treatment. So services like ours here, as all we do is we try and find ways to navigate the system to try and get people to where they need to be. But a lot of people that we engage with don't need a medical intervention. They don't. They just need some mutual aid, some support. They need some practical stuff around their housing. So I think it's the disappointing thing as I read the bill as it was presented was it did feel narrow to me. I can't deny that. And I think it didn't reflect the experiences that we have as an organisation.
Being a members' bill, it does need to be very narrow. It's not a government bill.
Sure.
So if it was a government bill, that's fair enough. But this really does need to have a narrow scope. But my question was, what wording would you use instead of a diagnosis of addiction? What wording would you like to see for people who do want to access treatment?
For me, I think it's the person's right to want treatment. I think to give it a word or a title, it's a really difficult thing. I don't envy your job trying to come up with a word for this, because there are so many words that have so many different meanings for so many different people. If somebody is coming to require clinical support or community support as well, because I take the point that this is not always about clinical support. There's some fantastic work done in the communities. I think when you look at the work done just within the Salvation Army in Scotland, they reduced overdose deaths by 43%. None of that was done with clinical services. That was done by love, compassion, relationships. That was all done in-house, managed by frontline staff. I think if we're going to be able to move this forward, we should be asking the people who are in receipt of services what words would they like to be used.
Thank you.
David Torrance.
Thank you, Convener, and good morning to witnesses. How confident are the witnesses that residential and detoxification services have the capacity to meet the increased demand that the bill's implementation would result in?
I mean, one aspect for me, I think, I don't think we have enough capacity throughout all the different types of service, but I think what's perhaps more important is we need a consistency of standards. So just accessing residential services doesn't mean that you're going to get the same thing in one part of the country to another part of the country. And I mean, that may be beyond the scope of this bill, but in terms of your question of have we got the capacity in Scotland at the moment, I'm not convinced we've got the capacity of a consistent enough standard across the different parts of Scotland. That would be my answer on that one.
And I think, you know, over the 20 years I've been in this sector, I've seen so many people successfully go through residential rehab, but I've also seen large numbers of people, it's not worked for them for a variety of reasons, whether it's there was no support before or after, or it just wasn't the quite right time or the right service for them. I think in terms of capacity, it's clear there isn't enough, because we run, you know, several pre and post residential rehab support services, and we're just seeing demand skyrocket, which is a real positive, because obviously people are like, I want to change. But our initial pre-stage, which was initially designed as 6 weeks, we're now looking at anywhere up to 18 weeks before we can then access a suitable residential placement. So we are definitely seeing sort of kind of pinch points in the system, because obviously the capacity isn't there. And I think another thing I'd just like to maybe talk about in terms of residential, every residential service is different, aren't they? The selection's different, the focus that they have is different. And I suppose that's another bit that we just need to factor in terms of how we promote better and quicker access to residential services. I think about the rehab in South Ayrshire, which is very outdoors and sort of kind of environmental focus, to some of the other ones which are a completely different focus and different entry criteria. So yeah, I don't think they have enough capacity is the kind of bottom line there.
We don't feel that there is enough capacity within the system. When we think about the clients that we work with who, over the last 5 years, the points of contact for the Salvation Army in Scotland, in terms of people that we're meeting with coming into our services, is increased by 70% over the last 5 years. And wherever there is the experience of homelessness, quite often that's a co-occurring issue with addiction as well. We know if we were to look just over the last 5 years, we've got roughly 3,000 people who can't or wouldn't access treatment. So, and treatment is full. You ask any worker at the moment, their caseloads are going up. I think the stress and strain on the system is continuing to increase. Therefore, I think the capacity issue is we are at capacity, so there needs to be additional resources if we're going to increase this. One of the things that I think in our evidence that we gave that we are concerned about is that what we don't do is increase one area of supports, for example, residential detox and rehab, at the expense of another, because we need a whole range of treatment options for people. We believe really, really passionately in person-centred healthcare, person-centred approaches, and therefore the person has the right to be really, really informed, really, really involved, collaboratively with medical professionals who are skilled enough to be able to do this, but to decide the treatment pathway as a collaborative process.
Now, how concerned are witnesses that the bill's focus on residential treatment could inadvertently deprioritise things like community-based treatments, harm reduction strategies?
We have concerns. I think we said that openly in our submission, that there are concerns that if we prioritise one treatment approach against another. When you look at the evidence base for harm reduction, I think as a treatment option for certainly the people that we work with, people experiencing homelessness, the evidence base is absolutely huge. We could sit here all day and recite the evidence base for this time and time again. But what's also really, really important is that within services, and only yesterday this happened, I was speaking directly to people in receipt of services, and some of them are saying that's the option that they want. They want to go into detox, they want to go into rehab, and they just don't feel like that's available. So we welcome within the bill that there is an emphasis on rehab and detox, but we would also say that should never be at the expense of all the other treatment options available to somebody as well. It's so difficult, I think, when you consider a life, certainly when you're experiencing homelessness, to think that you can have a life without the coping strategies that you've relied upon years to help get you through. So the thought of taking them away directly for some people is absolutely terrifying. So we would always advocate for a whole range of treatment options.
Jack?
I'd absolutely echo that. You know, abstinence and harm reduction are not in conflict. Most people who get to abstinence, most of the people I've seen who've gone successfully through residential rehab have had a period of time where they've accessed harm reduction services that have been part of that journey. And also in terms of person-centred care, people have a right to go both ways. I've also seen people go through residential care, come out and decide they want to go down a pathway of controlled drinking and successfully achieve that. So people should have the right to navigate their own route through harm reduction and abstinence. Both are important. And I really welcome the bits of the bill that talk about those range of treatments. And what's missing, though, and the risk is that if we don't name the harm reduction services, I know there's the line about any other approaches, but unless we spell out the harm reduction approaches, my fear is that we will put more emphasis on the abstinence-based approaches and that people won't have a route into them through the harm reduction services, like drug checking, like needle exchange, like we have drop-in harm reduction cafes that are really good at holding people until they are ready to make a choice to go into treatment. So I think we need both, and we need them both named in the bill. They're all part of the same pathway, and it's part of person-centred care that people can navigate which route is right for them at this point in their journey.
Can I just add on to the back of that? I think the mission of harm reduction within this has the potential to polarise the debate even more, because you're almost putting people into different camps. It's either this or that. And I completely agree, harm reduction and abstinence are not in opposition. They're expressions of treatment. And everybody has the right to treatment in that way, to choose their modality to be in as well. I think there is a concern that if we choose one pathway over another, it almost blames the person if that pathway isn't successful for them, in the same way that we should learn the lessons from housing within this. If we put all of our emphasis on housing first and it doesn't work for the person, they're the problem and not the system, and we need to be really, really careful that what we do with this is we don't blame the person.
Absolutely.
Anne-Marie?
Yeah, thanks, guys. I'm cognizant that I've been told to watch my tone. That's usually code for you're making us uncomfortable in the Scottish Parliament. So, with respect, if my tone rattles anybody, I'll suggest it's not the volume that's the issue,
Miss
it's the
Ward,
truth behind it.
Miss Ward,
let's be honest.
Miss
No
Ward,
one ever
if I can just interrupt you for just 1 minute. We conduct our proceedings here courteously. So that I was reminding everyone to do so. I would do that whether it was witnesses or whether it was a member of the committee. Thank you.
OK, but let's be honest, nobody ever tells harm reduction services to watch their tone. No one ever questions whether MAT works for everyone. Yet the moment we talk about detox or residential rehab, suddenly the room gets cautious and the qualifiers come out and we're told not to get too carried away, as if even raising the subject is dangerous. You say that detox and rehab don't work for everybody. Of course they don't, but nothing in this system works for everybody. And yet somehow it's only abstinence-based or time-limited treatment that are treated like the radioactive options. That's not clinical reasoning. That's ideological discomfort. And this isn't about pitting rehab against other services. It's about making all options genuinely available. And the bill doesn't take focus away from other pathways. It simply gives a legal footing to the full spectrum of care, including the ones that have been quietly erased or endlessly delayed. And you don't protect the system by silencing voices that are too forthright. You fix it by listening to them, especially when they're backed by thousands of families who've buried loved ones while waiting for the right help. So no, I won't be softening my tone, because when lives are at stake, civility cannot come at the cost or the expense of truth.
I've no further questions.
Thank you. Brian Whittle.
Thank you, Convener. We've heard a lot of evidence around the issue about being able to coordinate, sort of drug treatments with housing, with trauma treatment, with social care. Do you think the bill will help to promote that coordination by focusing our attention on how we cross those portfolios? Does the bill help to do that?
From what I've read, and it doesn't seem to me, so it will instill a right that someone will receive treatment, but it doesn't instill a right to housing, it doesn't instill a right to anything else. The main challenges that we face and the clients that we support face is not accessing mental health services and not accessing physical health services or counselling services. So I think that from reading and what I understand of the bill, and this is where maybe this whole process is about, making amendments and trying to make it better, and I think that's okay to do that. I don't see how that is going to help with those wider sort of social issues. So it might sort out the treatment bit, the narrow definition of treatment, but it might not sort out the other aspects of someone's life.
To do is to make sure that those who seek treatment get treatment.
And if that's how it happens, then I think it's great that someone will have that right to treatment. But I suppose what I'm saying is, and I think you alluded to it earlier, is that many people we support, it's housing, relationships, it's employment, it's money, poverty. These are the things that are sometimes more important to deal with first before we even get to talking about their addiction. And that is the reality that we see in our services. So.
Anybody want to add to that?
I think there is. We're having the debate, which is a really, really good thing, in the fact that we are here talking about treatment, and we're able to air the fact that treatment is much wider than a clinical or necessarily just a social intervention. It's a range of different things at different times to people. So there is the potential for it to do that. But we can't just define treatment as the clinical process in and of itself. It needs to be wider, and it needs to acknowledge that.
If I could just throw in another one. How do you think the bill can put emphasis on supporting a longer-term recovery beyond that initial treatment? How can we do that?
I think simply it just needs to be in there and be explicit. I think my experience of being involved in services, if that it's not set out, then I suppose how is it going to be delivered? And that might be more of a question of how it interacts with other existing policies and other frameworks. But certainly it doesn't make it explicit. It offers the treatment to begin with, but it doesn't necessarily set out what happens over a longer term period.
I had the opportunity to listen to the answers earlier this morning as well. And there is the need to acknowledge that so much what we would normally consider treatment is done within the community by people that are not even counted, by services, community groups, advocacy groups is not even counted. So again, there is the real potential for that, but we have to include it.
Would you accept, though? I mean, I 100% agree. A lot of the most effective treatment is being done by volunteers, is being done by third sector organisations in our communities, and we're all aware of them in our own communities. But would you accept that by almost forcing the government to be able to offer treatment when it's asked for, that will in and of itself mean that you have all of those services will have to be properly financed and properly supported, and actually that the very services that we need are the very ones that are being drained at the moment, and we need that finance out into those services. Do you think this bill has the potential then to almost pull them back into that mix?
I guess it has the potential, but again it would need to be explicitly in the bill that, just as Graham said, that follow-on support, that wraparound support, and again that wraparound support post-treatment is, or post, residential rehab or community treatment. What often it involves is other parts of the system like employment, housing, community engagement. And I think we need to spell that out if it's going to happen. Otherwise, the risk is the money goes into one bit and then people come out without that support.
Okay, I don't know if Anne-Marie online, if you have anything to add to that.
Yeah, thanks very much, Brian. No, just that, this idea that keeps being conflated, that somehow money is going to be removed from one part of treatment and another part of treatment, that's not going to happen. Like, if this bill is enacted, people will get the treatment that they are seeking. So, there's just terrible fear here from people that, their particular branch of treatment is going to lose funding. And, if we're supposed to be serving, the people who are asking for help, well, surely, we should all get behind that, rather than trying to protect our own organisations or our own interests. Thanks, Brian.
Yeah, just a supplementary to this line of questioning. I'm really interested in understanding how, if we look at it in its totality, so somebody's journey in and through services and out of services, if we get that right, as far upstream as we possibly could, we would then be able to actually prevent a lot of the harm that we see happen to individuals, whether that be the loss of custody of their children, interaction with the criminal justice system, homelessness, the inability to secure employment. So I'm wondering whether this right could potentially actually realise that at an earlier stage for an individual or not. So that's my question.
Yes, again, if it was more explicitly in there. And let me reinforce again, I am not wanting the residential rehabilitation, the prescribing treatments, the treatments that are listed, taking out of here. I want them in here. We have lots of people who are desperate to access these, and we want them. However, what we want as well is those upstream things. So maybe I can give you the example of somebody who is, say, drinking a bit problematically but not yet dependent, hazardously. If that person had the right to get a brief intervention much earlier on, and we were doing that harm reduction work much earlier on, we might prevent them needing places in residential rehab, and that may make those places available for other people. It may mean that, as you say, they don't lose their children, the physical harms are protected. So yes, upstream is really important, and that's why it feels to me there's a lack of harm reduction spelt out in here, alongside the other treatments. We're not asking one or the other. I think Lee's already said we want to get away from the idea that it's one or the other. It's part of the whole thing.
One of the things that worries me is if it's not explicit, quite often things that are not said are not done. Now, one of the things that I think everybody around the table would probably agree to is to try and eradicate and tackle homelessness. Yet in I think it was the 2021 Homelessness in Scotland report, it evidenced the fact that within Scotland, every 19 minutes a household is becoming homeless and 32 children every day are becoming homeless. Therefore, there needs to be an explicit commitment to go as far upstream as we possibly can to tackle this at source. I've never worked with anybody yet who wakes up on a day and starts to decide to use substances as a way of coping. It doesn't start on that day that they use it. It started 20, 30, 40 years earlier. And unless we go back to that point and we're explicit about going back to that point, we're going to continue to see this stream of people coming into services. And services are overwhelmed, staff are overwhelmed, service users are overwhelmed. So upstream work, that's where it all begins. It needs to be done at that point.
Okay, so I guess my question really was about how we ensure that somebody has adequate ability and the right to access what is going to work for them at the earliest opportunity to then prevent some of this down the line. So I know, Graham, you want to come in. I don't know if Anne-Marie has anything to say, and then I'll need to hand back.
Okay. Want me to go first?
Yeah.
Yeah.
Sorry,
Anne-Marie, I guess. And then
oh, great. Thank you. Yeah, you know, I'm really glad to hear this kind of honesty. Elena, thank you so much for that, because it lets us deal with what's really going on. And of course, this bill won't sort housing, it won't fix the broken benefits. And it won't on its own rebuild the communities that, you know, have been devastated by addiction. But here's what it will do, and let's not lose sight of how important this is. It will make sure that when someone finally reaches a point when they say, I'm ready, I need help, and they're not told to come back when you're worse, or we don't offer that here. It will guarantee a legal right to treatment, not just rehab, not just detox, any treatment deemed appropriate. That's what it says in the bill, and that includes all the harm reduction interventions. So this bill does not remove harm reduction. It does not undermine MAT. It does not close services. It protects them by making them part of a legally recognised treatment pathway that the individual has the right to access. If somebody wants a methadone script or a needle exchange, they can get it. If they want a detox bed or a rehab placement, they should be able to get that too. And this isn't about taking options away. It's about making sure that all of the options are on the table, and that people, not systems, not organisations, that they get to choose what their recovery looks like. And let's be honest, you can't stabilise your housing if you're using daily. You can't get back to work if you're trapped in a system that only medicates, not motivates. And you can't rebuild your life if you're dead. This bill doesn't claim to solve everything, but for the people we serve, the people who've been left behind, written off, or pushed through so many revolving doors for years and years and years, it's the one thing they've never been given: a legal right to be helped when they are ready. So yes, we need to fix the rest, but let's stop using the absence of everything as an excuse to do nothing. And if we can't pass a bill that simply gives people the right to the help they're asking for, then what exactly are we doing in this Parliament?
Just very briefly, Graham, because I know we've got loads of other questions from other members.
Sure. As it's currently written, I think it doesn't explicitly mention early intervention and prevention. It just doesn't. It speaks about that narrow definition of treatment. And I think that, you know, of course, that should still, you know, we support the intent of that right to treatment. However, it's not explicitly saying how it's going to do early intervention work. It's not guiding the system. It's not telling us that. So I think if the bill was to go forward, it needs to be explicitly mentioned, as others have mentioned. It's the way that it's currently written. It is a narrow definition of what we understand to be treatment. And at that point, for many people, it's almost too late, isn't it? Like they're at a point where things are so bad that they need medical intervention. We would much prefer that we see people much earlier than that. And unfortunately, the bill as it's currently written doesn't really capture that.
It needs to be a systemic focus. Because if we are looking for when the person is presenting at the door because they want treatment, we're misunderstanding the fact that when they need treatment, it's probably much, much earlier. And those support services around poverty, housing, health, homelessness, all those different things, they also need to be addressed.
Thank you.
Gillian Mackay.
Thanks, convener. Sorry, I was waiting for my microphone to come on. And good morning to the panel. Could I follow up with Graham in particular in the room just now about what was just said there about the potentially limited flexibility in terms of treatment options? It's something we've heard from a few stakeholders, that while there is a person-centred approach within the bill, it may inadvertently create standardised or overly medicalised treatment pathways. How, in the panel's opinion, could the bill be amended to ensure that that treatment remains genuinely personalised, especially from people who may need that longer-term psychosocial approach or support before being available or being able to take on some of those clinical interventions?
I think when we read that and we understood the balancing act that had to be undertaken to sort of try and capture everything and not have just a huge list of different interventions. However, I think when we look at the work that we do, we were really disappointed to see key bits of those not specifically mentioned. And it goes back to that earlier point I made, is that if it's not written down, it might not be offered. And I know there's the catch-all phrase at the end which says, "and anything else reasonably, you know, kind of expected to be offered," and I think that to me is so vague. And so we've kind of got that system at the moment, don't we, where it's kind of like it's open-ended. I think that we need to be a bit more specific in terms of what different types of treatments are available and what combinations, because I think actually that's not necessarily spoken about either in the bill. Is it, you know, detox plus rehab detox? Do you know what I mean? I think that would be really helpful too, because in our experience, people tend to need more than one thing. Yeah.
I think it's also understanding the role of the community, I think, in the actual treatment pathway as well, because treatment doesn't begin and end at certain points. It's not defined by a period of time. It tends to go on much, much longer. So I think there is the understanding not only of the early intervention, but the post-treatment support that's done in community, that needs to be recognised. Because I think there are so many community groups, if I think about our organisation and the community churches that the Salvation Army run, some of the best drug and alcohol work I've ever seen has been done in those services, and they don't even know that they're doing it. It's not even recognised, and it's not accounted for, and it's certainly not funded either.
Great. Sorry, on you go.
I was just going to agree really that what we need is this much wider definition of treatment or a response. Maybe the word is a response to problematic alcohol and other drug use, so that we're acknowledging the importance of working with people when maybe at this moment they're not ready to make changes, but they do still need support.
Anne-Marie?
Yeah, I'm just, you know, the claims that there's no prevention in the bill completely misunderstands what the bill is and what it's designed to do. This is a health rights bill. It's not a national strategy. It's not replacing prevention. It doesn't reject it. It simply focuses on the part of the system that's been consistently broken. Access to treatment when somebody is ready to get help. So, of course, prevention is vital, but you don't prevent deaths by denying people treatment when they ask for it. We've had, You know, the problem isn't that not that people don't know that drugs are dangerous. The problem is that when they realise they need help, the door is locked, or at worst, it doesn't exist. And the bill doesn't cancel prevention, it complements it by making sure that when prevention fails, there's a legal right to treatment. So that I think there's a misunderstanding or a deliberate conflation, I'm not sure, with people who don't understand, given evidence to the committee, that this bill is flawed because it doesn't try to fix everything at once. It's not a manifesto, it's a legal safeguard. One piece of the system that desperately needs structure and accountability, and that's, you know, that's what it's trying to fight for here. There's no better prevention than watching somebody get well. No poster, no toolkit, no campaign is more powerful than seeing somebody escape addiction and reclaim their lives. So I don't know why, you know, people keep referring to different aspects, housing even, you know, it's things that are outside the scope of this bill. I think, you know, I'm very concerned that that is deliberate conflation.
To come back to the members in the room, and if I could come to Lee first on my second question. Several organisations have warned that the bill's requirement for in-person appointments could exclude some vulnerable individuals or those who have barriers to being able to attend appointments for whatever reason, or those with mental health issues who may find attending appointments difficult. Would the panel support changes to the bill to allow for greater flexibility and greater use of telehealth and outreach models, for example, to reduce those barriers and make recovery within the bill more accessible and inclusive? And if I could go to Lee first.
This is part of our evidence that we submitted, which stated just that. I think we work with a population that, through a number of different issues, quite often long histories of significant trauma, histories of addiction, histories of poor mental health, histories of feeling excluded from the services that appear to be inviting them in through the door because of cognitive kind of issues or harm that's been caused over the years. I think to have a rigid system that requires in-person attendance at a specific point at a specific time is really, really difficult for our client group, and I'm worried that they would be extremely excluded from a model that was that rigid. So I think in terms of flexibility, what we need to do is not only to think more creatively about accessible sources, whether that be online, whether that be more telehealth kind of interventions as well, but also to rely on the workforce that we've got. I was in a service yesterday, and a lot of the staff feel that they are not included in the kind of treatment pathway to support the individual. These are the people who live directly with people in services, and they should be included to a degree to support the individual to get to appointments, and they're quite often an excluded, unheard group. So I think we do absolutely need to be as creative as possible, but involve the wider kind of circle. We talk a lot about the involvement of families within the treatment pathway, which is something we completely support. For a lot of the people who live in our buildings, the staff in their building are their family, and they're completely excluded from this as well. So I completely agree with you, yes.
Anyone else in the room looking to come in, and then I'll go to Anne-Marie.
Yeah, I mean, the vast majority of our services at With You are actually in rural and semi-rural locations, and when you were talking there, Gillian, I thought instantly about our Argyll and Butte service, which is Highlands and Islands, and I think the requirements of someone to get from Isla, for example, to the mainland, it's like, you know, mammoth logistical planning, and so I think that there needs to be provisions in the bill of online telehealth. It has to be flexible to cater for those needs, you know, and I think that it's probably something wider than just the bill, but we need to consider how we deliver and implement anything in our rural services, just because of the geographical challenges that exist.
Absolutely.
So, can I come in?
Yep, of course, Anne-Marie.
So, you know, again, this just isn't true. The Right to Recovery Bill does not require in-person appointments as a condition of access to treatment. This is another example of misinformation that's been circulating mostly unchallenged. The reality is the bill says a qualified healthcare professional must assess whether a person would benefit from treatment. It does not specify how that assessment is delivered, in person, online, over the phone or via multidisciplinary input. That is a matter for clinical judgment and service design, not legislation. The bill gives people a right to treatment, not a prescribed format for how services must engage. So the idea that this bill somehow mandates face-to-face appointments and therefore excludes harms and delays people is completely false. It's a distortion of the bill's intent and content. And if, you know, it's just simply not true. Let's not invent barriers where they don't exist.
Thanks, Convener.
Thank you. Sandra Gohani.
Thank you. So I want to just, before I move on to my topic, I want to talk about early intervention and the things that were discussed here. Along the line of a patient journey, for whatever problem they might have, whether that be addiction to alcohol or drugs, or whether that be a medical issue that they have, such as chest infection. There are multiple touch points that that patient has on their journey with services. And I think that when you have a members' bill, which is a very narrow scoped bill, it should not look at the entire patient journey. It needs to be very focused upon something. And this bill is very focused upon the people who are at the end who say, I need help, I need some medical intervention, and trying to improve that. And it is not to reduce the right of people to have early intervention, because that is vital, absolutely vital that happens, and cuts that are occurring in my area of Glasgow are stopping that early intervention from happening. That's got nothing to do with this bill. That is what is happening. So if we look specifically on this narrow bill, the person who has said, I want medical help, will this bill help them?
Based on your comments and definition, and then yes, it absolutely would, wouldn't it? So if someone requires medical intervention and it's enshrined in law, then yes. All we can do, Sandesh, in terms of service providers, people with lived experience and that as well, all we can do is share our experience as service providers and what we share. We're not trying to block things just because we don't like the bill or whatever. It's actually what we're trying to do is help scrutinise it, because deep down, we're advocates for the people that we support and the people that live in our communities, and what we want is for things to be better, not to be worse. So anything that we've said today is about making sure that all aspects of addiction and treatment pathways are considered. It doesn't mean it's an either or. All we're doing is just making sure that there's no unintended consequence, because we know at the moment that's what we see, isn't it? People getting denied entry into residential rehab, denied treatment. So everything that we've said today is not about saying, oh, it needs to include all these other things. It's just about we need to consider what the impact could be, because what we don't want is unintended consequence, and that's where I've always came from our organisation.
Can I add on to that as well? I think from the perspective of the Salvation Army, we believe that there is the potential for it to do exactly as you've explained. But I think in the bill being so narrow and almost not having the capacity to take on all those other additional early intervention kind of markers that we may well see, we have to understand those early intervention incidents are going to have an impact on the person's ability to represent themselves and to fight for their own rights within this bill. Therefore, if there is the right to contest, the right to a second opinion, who's going to support the person to be able to do that? And I think what we need to do is, if the bill, the way these bills are written is above and beyond my kind of pay grade and my level of understanding. However, what I do have direct experience of is that people struggle sometimes to be able to advocate for themselves, and what support will there be for them to be able to do that? Because it's one thing to give a person a right, it's another thing to give the ability to exercise that right, and I think we need to think about that on top.
Okay. So just, sorry, Anne-Marie, I don't know if you want to come in before I move on to further questions.
Yeah, thank you very much, Sandesh. Yeah, calling this bill too narrow is just another way of saying it does one job well, and that some people don't like that. The bill doesn't try to do everything. It doesn't rewrite every part of the addiction system. It does one crucial thing. It gives people a legal right to access treatment when they need it. Not a leaflet, not an appointment, not a pilot, not a postcode lottery, a right. That's not narrow, that's targeted, effective legislation. And we have had endless strategies that try to do everything and deliver nothing. What we don't have is a single enforceable guarantee that says, if I ask for help, you have to respond. So if the bill's focused scope makes some people uncomfortable. Maybe it's because it finally brings accountability, and that's what's really being resisted here.
Thank you. I'd like to move on to treatment determinations. In the evidence provided from both the Salvation Army and an organisation called With You, there was discussion about the attitudes of healthcare professionals and how the bill would create a power imbalance. But also there's discussion about the fact that people are being denied access to treatment right now from those professionals. So how can we improve the situation right now for people who want help but seem to have this power imbalance? And why do you think that the bill would create further power imbalance?
I think for us, this relates to the attitudes around substance use in and of itself. So I think a lot of the power imbalance or a lot of the issues of why people can't access the treatment that they need or they want right now, there is so much stigma around addiction that people already have ideas before they come into the setting about what is the right course of action. So I think in order to do this ethically and openly, so that I think the treatment or the determinant of treatment is an equal kind of process, we need to eradicate some of that first. We need to do some work there because that work needs to be done up front. I've walked directly into healthcare services with some of the people who I worked with experiencing homelessness, and the first thing that will happen is somebody will put gloves on before they even open their mouth and talk to the person. So that level of stigma that the people in our services receive is palpable, it's obvious. So in order to go in there and to think that this whole process is going to be one of equity and equality, I think we need to work on the stigma around addiction first and foremost before you do anything else. I think within this treatment pathway, within the bill, one of the things that we've commented on is the omission explicitly of harm reduction could potentially fuel the stigma that already exists around what is the right course of what is the right course of treatment for an individual. That's where we would come from on this.
Yeah. And certainly from With You's perspective, numerous clients and even out with the consultation process regularly tell us about really negative experiences they have, mostly out with the drug and alcohol sector, I have to say, so the wider health settings. And I suppose when we were looking at the bill and it was sort of focusing on the medical professional part, then I think the concerns from our clients were like, well, how is that going to improve when already my experiences are negative? So you might have a right, but it's not necessarily going to challenge the behaviours and the culture that remains or the attitude towards alcohol and drug use in Scotland. So that's really where those concerns came from. So I think regardless, whatever happens next is that we need to be able to support medical professionals if this is going to become if this is going to progress, because at the moment there are too many examples of, you know, maybe bad experiences that people face.
Can I just clarify, at the moment, do you think that we have a top-down bad attitude towards drug and alcohol?
Do we think
that there is a top-down bad attitude that is coming through to our health professionals?
I can't say that in every case, but I've experienced it firsthand, yeah.
I think it varies. It varies everywhere you go. So I think there's some really brilliant professionals who've got an active interest and really compassionate and caring. But I also recognise that the health system is under great stress and strain, and it's almost impossible to remain like, you know, how can you keep that level up at all times with the amount of work that they're doing? But I'm like you, I've been in numerous appointments with clients where the attitude has been shocking, as in, why are you here? This is your fault, and you go, you know, like that's all too common.
And I think within the bill there is the potential for clients to be able to call that out. But going back to the term early intervention, because it can be applied so broadly, what work will be done with the clients to understand their rights when they go into that room? Who's going to empower them to be able to argue for those rights? So that kind of the treatment, the determination of treatment is something that is collaboratively done. We need to be thinking about that, because a lot of the clients that we work with, when you ask about their experiences of healthcare, they've got some fantastic examples and they've got some absolutely atrocious ones.
Guys, can I come in? Hello?
Yes.
Oh, great. Thank you so much, Sanders. Let's not dance around this. Some professionals are saying that the bill would change the power dynamic between service users and providers. And to that I say exactly, it should. Because right now the power sits entirely with the systems, not the people, with unaccountable panels, opaque decisions and service providers who can say no without any explanation and without any consequence. The Right to Recovery Bill simply levels the playing field. It means that if a healthcare professional agrees someone needs treatment, that need can no longer be blocked by a budget, an opinion or a bureaucracy. That's not undermining professionalism, that's backing it up with a legal weight. In fact, it's a vote of confidence in professionals that their clinical judgment or their compassion should matter more than a finance panel, a gatekeeping service manager or a postcode-based policy, a postcode lottery. So yes, the power dynamic will shift. It will shift towards the person asking for help. And if that makes the system uncomfortable, it's long overdue.
A couple of things. Firstly, I'd like to really pick up on Lee's point that if this bill has a very narrow definition of what is available as a range of options to respond, that will steer what people feel they can ask for, and we'd need the advocacy to give that, broader, really collaborative care package. Because of the phrase healthcare practitioner, and I think this has already been picked up on, that could be, particularly in some rural areas, a healthcare practitioner, maybe a GP, who hasn't got particular experience in this field and doesn't know what's available. And what we offered in our submission about the bill was a way forward on this, an approach that could be used using the principles from the Self-Directed Support Act, which really builds in that collaboration between the person seeking services and the healthcare practitioner to really plot their own course through. And so if we could have something like that, I think that would improve the bill.
Thank you.
Paul Sweeney.
Thank you, Convener, and thanks to the panel for attending today. Just want to turn to the issue of timescales as drafted in the bill under Section 3, subsection 1. It refers to treatment as described in Section 1, subsection 3 to be made available to the patient as soon as reasonably practicable and in any event no later than 3 weeks after the determination has been made. There has been some written submissions from stakeholders querying this 3-week timescale after the treatment determination. Some have raised issues around appropriate pre-working with those who would be attending treatment to make sure they're stabilised and assessed, etc. So I want to really ask the panel, do they think that the bill's requirement that treatment should be made available within 3 weeks allows sufficient flexibility for necessary preparatory steps to be undertaken, such as assessment and stabilisation, or would that fall within the intent of the bill's idea of access to treatment being triggered at that point? I just would be keen to clarify that provision in the bill. Maybe start with Anne-Marie, if she would like to talk to it.
Sure, thanks, Paul. The fact that people are now quibbling over a 3-week maximum just shows how far we've become to there being no timescale at all. Right now, someone can wait 3 months, 6 months or indefinitely for treatment and no one is being held accountable. That's not a system that's operating with any sort of function. The bill doesn't say treatment must take 3 weeks. It says you can't be left in limbo beyond that with no action, no plan, no urgency. And if it can't be done sooner, which it absolutely should be in many cases, then great. But if it's a delayed beyond 3 weeks, people get a route to challenge that. And let's remember, 3 weeks is a legal safeguard, not a clinical prescription. It's the first time we're drawing a line in the sand and saying there's a limit to how long you can leave someone suffering. And by the way, the MAT standard same-day prescribing, how many people are actually getting that? None of our 123 advocacy clients had even heard of the MAT standards, never mind being able to access a prescription the same day. So let's not pretend that we're meeting tighter deadlines already. If the system objects to 3 weeks, maybe it's not because it's too short, maybe it's because it's the first time anyone has ever been told that time matters.
Just looking at the policy memorandum to the bill, and it says here that the bill establishes a timescale to begin treatment of at most 3 weeks after being prescribed it, but earlier if practicable. This is in recognition that time delays in receiving treatment impacts on the treatment having a positive effect if someone can become more unwell in the period between diagnosis and treatment, potentially becoming seriously ill and in a state of trauma. In addition, delays in treatment can lead to scenarios where a person cannot take up the treatment after a period of time passes. For example, if they have deteriorated in condition or lost faith that treatment will be provided that will help them. I note that the Salvation Army, with you and Turning Point, have raised concerns about the need for preparatory work to be undertaken before individuals can begin abstinence-focused recovery treatment. So just in terms of how the bill is drafted, is there a way to actually define that clearly, that as long as people are being entered through that process of preparation, that would account for that 3-week time period? Is that something that could be considered?
Is that to me, Paul?
Yeah.
Yeah, absolutely. You know, like, again, this is we're talking about people who are in crisis here, people whose lives are at risk. And if we can't guarantee that they'll be offered a treatment plan within 3 weeks, then what are we actually doing here? Because, you know, the 3-week timescale isn't an aspiration, it's the bare minimum, and the only reason it's being resisted here is because it finally holds services accountable for delays that they've been getting away with for years. So right now people can and do wait months. In fact, we had somebody who had been asking for residential rehab for over 5 years. Some never actually get treatment at all, and nobody answers for that. So if the system finds 3 weeks too ambitious, then it's openly admitting that it's got no intention of changing, and we're not asking for same-day miracles. We're asking for a legally enforceable deadline, a line that says beyond this point, someone needs to explain why help hasn't been given. And let's not forget the MAT standards, the promised 1 day, same-day prescribing. But when did the work, when we did the work and we found that none of our 123 people were supported had ever even heard of those standards, never mind receiving the care that was supposed to be met by them. So let's stop pretending that services are delivering tighter targets already. They're not. And why with this 3-week timescale matters, because it's the first time that anyone said enough. No more endless waiting, no more silent failures. Is that too much to ask? You know, if it is, then we're no longer talking about capacity, we're talking about collapse.
I just want to turn to panellists in the room maybe to pick up on that point. I know that in written correspondence there's been mention of, for example, some people may require at least 6 weeks of psychosocial interventions and practical organisation. Just wondered, in considering what's been said so far, whether this could be, the drafting could be tightened a little bit.
Okay. I think the 3 weeks target's been in for as long as I've worked in the sector. National waiting times, right? And as a third sector provider, we've always strived hard to meet that target. There are fundamental challenges there in terms of how it's currently maybe being met or not met. So it was good to see that the 3 weeks was there. It is a bare minimum, I agree. I think some treatment can start straight away. And that was the bit that maybe wasn't fully explained, because I think that some treatment can start same day, next week, and I think that maybe should be reflected in the bill if it could be. But then likewise, sometimes there are waiting lists for residential rehab. Unless we have a huge increase in capacity, I don't know how you get round that. At the moment, or previous guises of waiting times, people were counted as soon as, what did they call it, the clock's ticking when you got your referral in. So I think we need to be careful that that doesn't happen again. I think what's the most important thing is that people actually see someone and their treatment begins. So whether that's support, assessment, one-to-one, group work, whatever, I think that's more important. So it's good that there is a sort of time scale, but acknowledge that it's been a well-kent time scale in the sector for a long time as well.
Yeah. From our point of view, a 3-week wait for residential rehabilitation is appropriate, and we'd really welcome that. However, as Graham's already said, there are many other treatments that are needed more instantly. Access to somewhere like our crisis service, it needs to be within 24 hours often. So what we wouldn't want is that 3 weeks to become, as has happened with other waiting list targets, it becomes a barrier. And we just wondered whether this could be made more subtle and there be a more nuanced approach to waiting times. So 3 weeks is the absolute minimum, but making it even clearer that that's for this type of treatment, say MAT, for instance, we could add in the legal requirement for MAT to be within 1 day, could be added into this bill. That's what we're looking for.
One thing that we would hate to see happen is the critical, admirable goal of, I think, that 1 day kind of entry point for MAT standards, that's not threatened or deprioritised as a result of another timescale coming in. We don't want to see one sacrifice for the other. One of the things that I think we've submitted as well, and it goes back to a point I made earlier around what constitutes treatment. Because if you look at it in its broader sense, treatment always starts on day one, because treatment is defined by the relationship that you develop when you walk in through the door. So it always starts right from the get-go. That relationship is really, really important. We do have to understand the need for preparatory work for stabilisation. For some people require the opportunity to go straight to detox. We again need that whole range of options about what defines treatment, and that needs to clearly be spelled out.
That's helpful. I was also wondered, the point was made earlier about resource and capacity, but surely creating that clear demand signal would indicate where there is a gap, and maybe that would be helpful to have those expected target times against each type of treatment and each pathway, so at least there's actually a clear signal of where we're not meeting those standards. Would that actually be helpful if it was defined in the bill?
Yes, with the caution that we wouldn't want to create unintended consequences that often happens with these waiting times. But yeah, there's absolutely a case that, as Graham's already said, people are waiting far too long at the moment for instance, residential rehab. So yeah.
Anne-Marie, would you like to come back in?
Yeah, thanks very much. With respect, claiming that a 3-week maximum wait could become a barrier is completely backwards. The real barrier right now is that people are being left for months, sometimes years, without any timeline, any urgency, and no right to challenge the delay. The bill doesn't stop people getting treatment sooner. It ensures that they're not forgotten. The 3-week cap is a safety net, not a waiting period. It says you must not leave someone hanging beyond this point without action or accountability. It's a deadline, not a delay. And if anyone's genuinely worried that services will suddenly slow down and say, we'll wait until day 21, that's a failure of leadership, not legislation. If a system treats a legal minimum as a target, that tells you everything you need to know and everything of why this bill is needed. And let's be honest, people already face huge barriers, but they're not created by timescales. They're created by inertia, gatekeeping and unaccountable systems. This bill challenges that, and that's why it's been resisted. So no, the 3-week limit doesn't build barriers, it builds boundaries for a system that has had none for too long.
So you're,
it's about
the
3-week kind of time limit. That I think if we use the 3-week time limit to all of a sudden become an unobtainable target because we don't resource the ability of the services that we're talking about here to be able to deliver on that. One of the things that I'm really concerned about is that is going to put increased pressure on frontline staff who are already feeling isolated, who already feel guilty, who already feel that they can't make a difference in the work that they currently are trying to manage with this target on top. So if we are going to put that aspirational idea that people can get into treatment in 3 weeks, that is going to require being resourced as well.
So I think, if I'm correct in just my understanding of this, the issue is that some treatments can begin same day and they should be expected to begin same day, and one shouldn't expect that then to become the norm that it's dragged out to 3 weeks. But in cases such as residential rehab and access, that pathway, whether it's the initial psychosocial assessment and preparation, that would definitely be expected to be starting and getting underway within that 3-week absolute maximum period. Is that what I'm clear about, that the 3-week absolute deadline is more to do with the residential pathway than, say, for example, MAT standards beginning in day one? That should not be considered something that's fine to kick into the longer grass over a 3-week period. Okay, that's fine. Maybe there's some helpful ways we can adjust the language in the bill and just to clarify those differences in approach. Thanks. Just also wanted to turn to a definition of treatment to provide, just currently as the explanatory notes in the bill state that the bill sets out a non-exclusive list of treatments that may be provided, and subsection 6 provides that the Scottish Ministers may add to that non-exclusive list by regulations. Are are members of the panel content that the bill's definition of treatment provides suitable flexibility to accommodate evolving best practices in drug and alcohol recovery and to respond to changes in substance use over time? Maybe start in the room if anyone's got a view on that. Yeah.
I think what we're seeing, obviously, in recent times is obviously a real change in the types of substances that we're seeing on the streets. You know, we're seeing an increase in illicit benzodiazepines and synthetic opioids, which is of real concern. But I think probably one of the key things is around polysubstance use. And I think that we just want to make sure that, you know, in our intent from the get-go around the bill is to make sure that those people who currently are not necessarily always being fully supported because they use non-opiate drugs or they're not drinking alcohol. So as long as the definition captures those groups of people, then that would be the only thing I would be suggesting, is that we need to make sure that people are not excluded unintendedly. It's not an intentional act, but we know how the system operates just now, so it just needs to make sure that it improves on what we have. So,
yeah. For every use of every drug, there's not always a clinical intervention that can support it. So the explicit need for psychosocial and community-based support needs to be made, because that's where most people, I think, these days, as kind of drug use evolves and changes and morphs, we're seeing an awful lot more people not being able to fit into current clinical interventions. So the need for community psychosocial support is absolutely of paramount importance. We can't miss people in this. Polydrug use is what's killing people.
Yeah, I'd echo that. And I also think, even with the list of treatments that are there, what we need is careful definition of treatments, because they often mean different things to different people. So one example is stabilisation services, which are mentioned in the bill, and really welcome seeing them there. It's really important. But we also need to define what we mean by that, and make sure we're all meaning the same thing. If you've got a right to ask for it, we need to know what it is. So there may need to be, I don't know, some way of defining that in a bit more detail.
It was, I think, in the back of the bill, one of the things that we picked up was exactly the point that you made around stabilisation. Stabilisation, again, is one of those terms that can potentially be really, really loaded. Stabilisation is about literally that, stabilising the person. When we look at the glossary at the back of the bill, stabilisation was defined as stabilising with a view to reduce. That's got a motive within it. It's explicit within there, with a view to reduce. That's up to the person to collaboratively say, this is what stabilisation means to me. And for some people, the best quality of life is to optimal dose and to leave them there for a period of time to be able to stabilise all the peripheral issues that go along with addiction. You can't say that it has a motive which is to reduce.
Just to be clear, as the bill is drafted, section 1, subsection 5 and 6, are you content that there's sufficient flexibility there for the Scottish ministers to include the nuances you're referring to, or would you want that amended on the face of the bill to include specific mention of these provisions in community-based support?
I think it was explicitly mentioned.
Okay.
We think.
Right, okay. That's helpful. Anne-Marie Ward, just wondered if you had any views on this,
yeah.
the subsection 5 and 6 in section 1 in terms of how it's drafted.
Yeah, I'm happy for that to be amended as well, but it's interesting that we're quibbling over the definition of treatment. Like, really, like, treatment is already defined in law and clinical practice and in the NHS Scotland Act itself. The bill doesn't invent a new meaning. It uses what's already recognised in health legislation: detox, rehab, MAT, psychosocial support, harm reduction, peer services, and anything that helps someone reduce or recover from dependency. This isn't vague. This is standard practice, and it's telling that no one seemed confused about what treatment was when they were denying it. It's only now, when people might actually get a legal right to access it, that we're pretending the term is ambiguous. So we don't ask for a line-by-line definition of treatment in cancer care legislation or mental health rights, because we trust clinicians to apply their judgment based on need. The same should apply here. So let's not insult the intelligence of this Parliament or the public by pretending this bill is unclear. The only thing unclear is why some are so desperate to keep access to treatment vague, unchallenged and out of reach.
I just want to also ask about the financial memorandum and whether you feel that takes appropriate account of potential costs if treatment options as defined in the bill were to be expanded. Just to see if anyone in the room has a view on that.
Yeah. Thanks for the. I mean, obviously, I think it was welcome to see that there was at least some consideration given to increasing the resource to support the implementation of the bill. I think what's less clear is how much money is actually required. Like, I think we sit in a system that, do we have enough resource currently to do what we're doing? So never mind maybe potentially increasing capacity and demand for services. So I think we just need to understand that whatever money is put forward to support this is enough to do what it's asking to do. So I think that was the bit that it was welcome to see it, but it wasn't clear to me in terms of whether that would be enough resource to support all the different parts of the bill.
I think as well for us to come down to the finances, if we don't pay for this now, we're going to pay for this elsewhere and a bit later on. So I think the need to properly financially resource this whole process, I think, is absolutely vital, but also taking into account the money that we don't see that's being spent by third sector organisations where they're doing a lot of the community relationship work that also feeds into preparing somebody for treatment as well.
Anne-Marie Ward, do you have any final points to make?
Yeah, I mean, the financial memorandum is, for me, it's like, is that if that's bothering people, and like there's thousands of people dying here, and frankly, I think we've lost sight of the real crisis. The bill doesn't demand new treatments. It doesn't require building new facilities, from scratch. It simply creates a legal right to access the treatment already available, the same treatments the NHS and the third sector is supposed to be offering now. So the idea that this will somehow bankrupt the system, it's a myth. If anything, it will force the money to follow the need, not the ideology, not the postcode, and not whatever the quango happens to, or whatever quango shouts the loudest. We should be asking ourselves this: where was all this concern about the financial memorandum when tens of millions were handed out to quangos with no measurable outcomes? Where's the scrutiny over funding in the MAP programmes that have seen no reduction in drug deaths? This bill costs a fraction of what Scotland already wastes on failure, and if we're worried that implementing rights might cost more than maintaining decline, then maybe that's a price worth paying, because the alternative is what we have now, an expensive system that lets people die with no legal recourse. So yes, the financial memorandum matters, but let's not pretend it's a reason to stall this. Justice costs something, recovery is worth it, and doing nothing has already cost many, many families much, much more.
Now, my colleague Gillian Mackay had, I think, asked a question to yourself, Mr. Ball, about in-person meetings for determination, and I think there was. So, looking at the bill as it's written, Section 2, subsection 1D, it does say the treatment determination is made following a meeting in person between the relevant healthcare professional and the patient. But given that the member in charge of the bill is currently in the room, and he obviously heard the concerns raised by the witnesses about that particular issue, I'm sure he'll reflect on that and perhaps be able to speak to the committee about that particular subsection of the bill when he is in front of us in a couple of weeks' time. Can I thank the witnesses for their attendance this morning and for their evidence? And the committee will meet again next Tuesday when we will consider further the Right to Recovery Scotland Bill. And I'll conclude the public part of this meeting today.